good morning, everyone, and welcome to our second to last PerfWeb, and it's going to be the last faculty forum from Vanderbilt for this year, and also our last Knowledge Nuggets with John Ingram for the year of 2021. So we've made it through another year of COVID. We now have Omicron, so that should be interesting. It'll be interesting to hear from Matt and Joey what they're seeing out there in Nashville. I can tell you here in Houston, we're really not seeing a whole heck of a lot. I know people are getting sick, but they're not ending up in the ICU and on the vent and on ECMO thus far. So we'll see. Okay, so let me get through my housekeeping notes before I bring Nashville onto into the system. Our sponsor, of course, HET. We are currently still hiring. We're continuing to grow. We're also moving into the world of ECMO specialists. So if you are an RN ECMO specialist with a bachelor's degree in nursing at least and have critical care experience, we are definitely interested in talking to you, so please reach out to us. We're going to be doing some really neat stuff with ECMO, not just at the bedside taking care of patients, but also in the education arena with that. Our social media, please take a look at our YouTube, our Twitter, our Facebook, our LinkedIn, and like, follow, share, subscribe, give us the thumbs up, click the bell icon so that you get notifications, and most importantly, please leave comments. Germane comments, not just gibberish, but the more comments we get, the better it is for our rankings. And I think, and unless somebody correct me if I'm wrong, but we are number one on YouTube at this point in time. In perfusion education, our intention is to be number one in medical education on YouTube and the other social media platforms that exist. Please check out our websites, perfusioneducation.com and perfweb.us for our upcoming events for 2022. And for our library and your ability to get all of your ABCP Category 1 CEUs through us, actually all of your CEUs for your 3-year cycle. You can reach out to us at contact us at perfusioneducation.com. We also have a call-in number, so if you want to call, be live on the air. We're also going to be improving this. We've got some real neat stuff coming up in 2022. I'll tell you a little bit more about it. Let me get through this. Our MediWeb app, we're going to be doing an update on that. So if you don't already have that app, please get that app. It is a really cool app, and there's two apps. There's the comprehensive app, which is the critical care perfusion app, which has all the things you see there on the screen right now. But there's also a standalone IV calculator app so that if your spouse, significant other, colleague, friend is a nurse in the critical care unit, in any unit actually, this IV calculator is really a tremendously useful tool. So please check them both out, but if you get the critical care perfusion app, you get the IV calculator incorporated in it. Our podcast, you can go to your favorite streaming software, check out PerfWeb, and you can listen to our programs while you're driving to work, you're on a drive someplace. And of course, if we're live like we are now, you could actually be calling in and being live on the air, much like you do a radio program or any podcast. It's a pretty interesting thing. But as I said, we can go ahead and go off of all that stuff. And I'll just tell you a little bit about 2022 that's coming up. So we have some new streaming software that David, our production manager over there, is learning how to use, which is going to enable us to do some really new and interesting things. We're retooling the studio itself to add more green screen, more simulation type stuff. We're continuing to develop our relationships. Of course, you're going to be seeing Matt and Joey here in just a few moments from Vanderbilt, and their involvement in this has been so incredibly positive, and I can't thank them enough. I want everybody also to make sure you thank them as we get through at 2021, as I said. So we're doing all of those things, and you're going to see a big difference in 2022. Also, June 23rd, 24th, and 25th, I've already called Matt and told him that him and Joey and Dr. Hoffman from his group have already been assigned programs at the New Orleans conference in New Orleans at the Renaissance Père Marquette, and it's going to be absolutely a wonderful conference. We're going to have a tremendous Crystal Heart Achievement Award recipient, which will be a surprise. He doesn't know yet, so first he has to accept, but we're going to be meeting with him very soon, and I think you're going to find this to be a really good conference coming back from the haze of COVID, if you will. So we're going to move on with life, and hopefully this is going to be our best conference ever is what I'm hoping for. So let me bring in Matt Warhoover and Joey Lepore from Vanderbilt. And welcome, guys. Good morning. How are you? Hey, good to see you. I heard you're working really hard out there. That you guys have been just blowing up, and I don't know if that's from COVID from your side or if that's just from post-COVID, all these held off hearts and transplants and everything else that you do at Vanderbilt, which is the cause of all of the uptick in acuity and volume.
Well, I think it's a little bit of all that.
So are you
reverb, Joe?
I'm sorry?
Do I get any reverb?
I'm not hearing it. You sound good to us.
Perfect. So, no, I think it's a little bit of everything. Our COVID numbers have not gone up like you talked about. We are laying in wait to see what Omicron brings. But I think it's a little bit of everything. I think people are starting to come back out and do normal visits in addition to the telehealth visits. And I think it's a kind of a wave, if you will, of all these pushback or pent up office visits and caths that we're seeing. It's not specific just to Vanderbilt in Nashville. All three major medical centers in Nashville are extremely busy.
Mm-hmm.
Perfusion's a tight group, as you know, and so we keep in contact with our colleagues across town, and they're just as busy.
Yeah. So it's interesting because I don't know if you're seeing this, but in here, I have several colleagues and friends now who either had previously experienced COVID or are fully vaccinated and or fully vaccinated with a booster who have now gotten COVID again, but their symptoms are different, which I'm hearing with the Omicron, you don't get loss of taste and smell, but they feel horrible and they're sick, but they don't have the respiratory component where they're short of breath or having any of those kinds of issues. A mild cough is about all they're really experiencing, but they can breathe fine. They just are febrile and they feel really bad. And they've been tested and are positive for COVID, but they don't know if it's the Omicron variant or it's just some other Mu or Delta again, or just nobody knows. What are you seeing and experiencing there?
Yeah, Joe, like Matt said earlier, our numbers aren't drastically changed. There's a slight uptick. I think we were down in the teens in the hospital last week. I think we're just shy of 30 now. I think we had one on the vent last week. I think we're up to 3. So nothing drastic. Like you said, I think it's a little too early to tell, or even find out if it is the Omicron variant. But yeah, the acuity is not quite as bad as what they're, or I guess it's not bad yet. Don't know what will happen. I think it's going to take some time to figure out, if this is going to be, as transmissible, or there's no telling. I think it's just a little too early to panic or anything like that. So. But yeah, I mean, they're making preparations and everything like that, anticipating an uptick, after the holidays, things like that. But yeah, I think it's just kind of unfortunately like a wait and see type deal.
Yes. Well, I think you're. Yeah, I agree. I think you're 100% right. Both in transmissibility and virulence, we just don't really know. And of course, we don't know if people who are getting it again, if it is Omicron and they are vaccinated, if it would have been worse were they not vaccinated. The new vaccine, I guess, that deals with the more specifically with the spike protein differences that exist with this one, whether we're all going to have to get yet another booster. It's just hard to say. I wish I could figure it all out, but I don't know. I agree with you. We don't know where it's going to go, if it's going to go anywhere. We just have no idea. And so, are you seeing? I've heard that there's push out there, governmentally anyway, to start backing off elective procedures again to save room for another surge of some sort. Are you guys doing that or seeing that or considering that?
Not to my knowledge. We kind of get updates every Monday, but we have not heard that with our with our chief of staff or the hospital administration hierarchy. But in defense, even in the the biggest peaks of the first wave, second wave, and maybe Delta, if that's how you're going to categorize it, we really only did preventative measures that first wave. And it was more staffing. We would have 50% of our staffing in hospital for a week, 50% off, just to try to. We didn't, in the beginning, didn't know how transmissible it was. But we really didn't slow down as far as cardiac surgery wise. Cardiac surgery did not slow down. As far as elective cases, unfortunately or fortunately, however you look at it, we don't. A large part of our casework is not elective cabbage. It's in fact, that's a very small percentage of what we do. So we weren't really affected very much as far as about the elective shutdown.
Yeah, that's interesting because we do come from such different worlds. Almost all 90% of our stuff is scheduled and elective, and 90% of your stuff it's go time. But you probably have a very almost predictable it's go time because of just the nature of your beast. And we have like when we get an emergency, I mean we're pretty adept at it now, but even still, when we get an emergency, it's like, oh, we got an emergency, we got to go. It's like, and for you, it's, oh, we got an emergency, we need to go. It's like how we view things so differently through our experiences. So I know that you're going to be talking today about your year in review, your 2021 heart transplantation. And of course, in 2020, I do want to tee this up. You were the world's leader in heart transplantation. And I'll be interested to see how that evolved through 2021 and if you've maintained that distinction. So with that said, Matt and Joey, again, thank you so much. I know you guys are busy as heck and tired. You look tired, actually. You look good, but you look tired. Joey's just sort of hunched over. He's looking older than you, and he's still really young, but he's hunched over already. But with that said, I'll let you take it all over and talk to us about your heart transplantation 2021 versus 2020.
Well, in defense of Joey, he's hunched over because he carries me most of the time. His back is sore, Joe.
Happens when you carry the team, Joe.
I understand that. Anybody's name is Joe or Joey, we all carry it. I know. I understand. I've been lugging Tammy around. I'm her personal chauffeur. Everywhere we go, I have to drive her and buy her breakfast, lunch, and dinner.
Best job in the world.
And coffee in the morning. All right, let's let them do their thing.
All right, well, we wanted to just kind of review year end, the 2020 data versus where we're at 11 months in. This data was actually good as of midnight. So welcome December in, but we're 11 months into this 2021 calendar year. And so let's get at it. So a little bit of terminology to talk about. So we do four different types of, 4 different categories of heart transplantation. And just for the acronyms, this is what our organ procurement team uses as their acronyms. And so I wanted to kind of give you the terminology and what the monikers and the acronyms were for it. So the AH is our cold storage. So it's typically your traditional heart transplantation comes from a brain dead donor with a beating heart. They're pronounced dead prior to coming to the operating room. So the patient is no longer a patient of the hospital. They are now an organ donor that doesn't have an armband with a patient name. They have an organ donor armband, and we do a traditional beating heart, cross clamp, cold flush solution, and then explant into a cooler, transport traditionally ground transportation to a plane back to ground and back to the hospital, or if it's locally in town, it's just ambulance from hospital to hospital.
So Matt, can I just interrupt, just for the sake of the argument, AH?
Yep.
I'm assuming that just stands for allograft heart.
That's correct.
Okay.
Yep. And then your DCD-H is your because we do DCD livers and we do DCD lungs. Yeah. So this is their acronym. And the reason I'm going through this is the next slides. They utilize these acronyms. So your DCD heart, it's a Transmedics OCS device. We use the Transmedics OCS DCD protocol, which traditionally you do a little bit different on the management of the heart, but the primary difference in the setup is that you're using a bag of levothyroxine as an additive, a drip solution. It's a constant drip. That's really the main difference between the DCD Transmedics and the traditional Transmedics OCS. So the donation is after cardiac death. The patient is considered a patient when they're brought to the OR. There is a team at the local hospital that takes care of that patient. They withdraw care either with or without the family in the operating room, depending on the circumstances. The patient, there are strict criteria that Transmedics has set, and it's below 70% on the SVO2. When that drops, the clock starts, or a MAP of less than 50. And so that's when the clock starts. So either one of those thresholds, as soon as the blood pressure or the SAT drops below either of those two marks, that's when the clock starts. And we have 30 minutes for the patient to actually expire. Then there's a 2 to 5 minute standoff period, and then the patient is reassessed by the physician that's taking care of them in the operating room, and then they're after the 5 or 2 minute standoff, they're checked for a heartbeat, checked for vital signs, and then they're declared dead. That's the time of death, and then the procedure starts of going in and getting the heart. They do a cold flush, just like your traditional heart transplantation. They explant the heart. The difference here is that they implant the heart back on the OCS machine, and then we more or less condition and recondition the heart in transport back, and we have somewhere between 8 to 14 hours. At 5 to 14 hours is really reasonable of looking at the heart, checking lactates, making maneuvers to try to more or less recover the heart so it's capable to be implanted back in our recipient here. And the final call is the primary investigator, the PI of the study here. And so he declares whether we're going to take the heart or not. Once they get back, once we get back with it, he takes a look at it. The implanting surgeon, if it's not him, they look at it, they discuss it, and then we move forward with the implant, or we reject it and we turn it down.
That's a lot of work.
It's a lot of manpower.
How many? Do you mind if I ask how many times have you gotten a heart back after an 8-hour ordeal and it's been rejected?
That's next slide, Joe. I'm going to get to you.
Sorry.
No problem. And then so I don't have that data right off the top of my head, but we will get to it. The third is the expand trial, and that's your traditional brain dead donor that goes into the operating room. That the patient does not. It's not a patient any longer. They have a time of death prior to going to the operating room, and it's very much like the cold storage that in the top bullet. The only difference is either A, it's a marginal heart that we're a little concerned about, or two, the length of travel for your traditional storage is too far for hospital to hospital transport. Here in Tennessee, or Nashville, we've gone all the way to Las Vegas, Albuquerque. Where else have we gone? That's pretty far.
Like Phoenix, Arizona,
Durango, Colorado.
Yeah.
We've done some long trips. 3 hours and 45-minute, 4-hour flights. And you're talking about in cold storage. We all know that 4 hours is about the limit. And so you're with 3.5 to 4-hour flights. You're not even in the hospital with the organ, and you're over that 4-minute or 4-hour threshold.
Yeah.
And then so finally is the Ecmo Dcd. That's what they like to call it. It's just easier. They don't NRP. DCD is actually what it really is, and that's normothermic regional perfusion. That's donation after cardiac death. So that's a DCD. Same way with slide 2. The only difference is that we have continued to. We're not set by limitations of the study. It's the exact same procedure that happens in what I talked about, the Transmedics OCS DCD. The difference is that we're not using the Transmedics device, and we have continued to modify and push the limits of what we find is the parameters. So in the beginning, we used the DCD parameters that Transmedic put, the MAP goal of 50 and the SVO. Then we pushed it to 40 minutes, and then it was 50 minutes, and it was an hour. And now we've actually dropped the SVO2 limit at all. We just worry about a blood pressure MAPS less than 50. And the thought process behind that is a probe on the finger is probably not indicative of what is really going on at the coronary level of what your oxygenation is. And so just because we've dipped below 70 on a finger probe, the body's natural response is to shut down organ systems in least vital importance. Your skin and tissue, it'll contract first, and everything, just as a septic shock or some sort of hypovolemic, things get shut down in reverse order that's of importance. So a finger probe is probably not the best measure of what is going on at the coronary level. And so we've decided to push the limits to just look at MAPS. And I think what's the longest we've gone about? It's been greater than an hour.
Yeah, yeah. I mean, yeah, anything over an hour is kind of a surprise to us, but I mean, we've had success with it, so just keep it going.
So and you know, every time we push the limit, we do a little retrospective look and go, okay, was it because it was a 18-year-old or a 19-year-old donor? Was it because you know we had really good normothermic regional perfusion afterwards? Did other organ go with that heart? Because when we have a liver team and we have a lung team and we have a kidney team and we have another abdominal team, whether it be pancreas, when they're doing their dissection, we're fully heparinized. We lose that they're just not used to the blunt. They're not used to the dissection and the mindful cautery use. So we're going through a lot of blood at times when we have more teams in there, and the perfusion is not as good as it could be because you're dealing with multiple teams and multiple. I don't want to say agendas. That's a strong word, but everybody is concerned about their organ. They don't really quite understand the importance of the regional perfusion of the organ. They're used to the traditional DCDs where it's fine. A liver and a kidney can be taken even after without perfusing on a DCD. So their dissection is a lot different when there's an active blood pressure, especially when you're trying to hyperperfuse the organs to recover them as fast as possible. If that makes sense to you, Joe.
Yeah, it does. It's very difficult to do when you're trying to, you're trying to perfuse the patient and you have, like you just mentioned, all of these teams. You're trying to make sure you have a good coronary perfusion pressure, you have good, physiology. You're washing the lactates out, and then they're just they're perhaps not as aware of the need for really good hemostasis while you're doing these dissections, and you've probably got low flow situations, chattering, I'm sure, in your line, struggling, having to give bicarb, you've got blood loss. Yeah, I could see it as being a very complicated thing to do. And I actually had a question. I don't know if you want me to ask the question now or you might wait, but the question that I had is, because of that, would it not make sense, because you have all these protocols, like the Transmedics protocol, you have the pressure gets down, you have the period of time before you have cardiac death, and then you have the standoff period, and then you go in there and you move real fast, and all of these things that are going on, would it not make sense to have it more protocolized in terms of having coordination with a coordinator? In other words, there is somebody who is keeping all of these teams working in a way that maximizes the preservation of each of those organs, and because I'm respectful of the fact that they're worried about their liver, they're worried about their kidney, they're worried about their whatever it may be, but if you don't work in a way that maximizes the protection of all of those organs, including the ones like the heart, which are going to be much more sensitive, that you could really not have the best graft that you would want.
Yeah, it's really the OPO that is supposed to be the ringleader, but Joey's been on enough of these. He can comment. It's really we have a protocol that we send to the OPO and we have a timeout that our cardiac surgeon talks with in the timeout exactly what's going to happen. I just think this is so new, in my opinion, and that people are really they're really, I don't want to say dismissive, but they're really focused on what they're doing, and in the timeout, it's almost we've had it to where people were like, we didn't know you were going to do that, and in the timeout, it was cleared out. It was clearly spelled out, and then they go to ask another organ team, and they're like, that they didn't say that, did they? They look over to the kidney team. The liver surgeon will look over at the kidney surgeon and go, did they really say that? Yeah, that's what we talked about in the timeout. It's almost they've gone through the motion so many times of a traditional, and they don't it's almost like they're just checking the box for the timeout. It's almost impressive that you go, were you not listening? And like I said, I think it's one of those things, kind of like in perfusion and pilots, anything that has a check off. If you've done and you go, oh, this is just I'm just here to check the box. Please be quiet. Just listen. Have no idea what people are thinking about or at the time, but it is not. They are not engaged in the timeout. It's almost like you want to ask them, okay, can you spell it back to me, or can you talk me through what we're going to do? That's really the suggestion that we're talking about doing, because it happens multiple times. What do you think, Joey?
Yeah, no, absolutely. And it's an unfortunate thing, and it's a different topic. Is getting comfortable with timeouts. But in this instance, yeah, I mean, you'd be surprised how they're not grasping the concept of what we're doing, and or they're thinking that we're putting the heart on the box. We've ran into that a few times where they're thinking that we're bringing the OCS in, and they've seen that before, so that's what they think we're doing. And no, it's something totally different. And I guess it throws them off, and we've had also excuses of just there's not enough data out there, which truly there's not. I mean, it's because it is so new, and so yeah, I think having somebody there to spell it out for everybody, which typically falls on the OPO, who Matt said is the ringleader, is supposed to coordinate all that information, on what everybody's supposed to do, and then typically we try to have an overall timeout in the room, but also our cardiac surgeon tries to speak, participate.
Yeah, and that's the thing. I do find this to be the case where when you have multiple teams like that, there's a lot of egos involved in this industry. I think everybody knows that, and just because you're a heart surgeon, who are you to be the primary coordinator? It's almost as if I think it would make more sense to have it as a requirement for reimbursement, for something that is more officially codified, that this is the person who is the coordinator. And the OPO is supposed to be as you said, the ringleader, but you have all of these other people who, varying degrees of paying attention and or listening or hearing or concentrating on that whole big picture and not just their little microcosm.
Yeah, Joey, Matt,
Joe,
I wanted. May I ask a quick question about that? Do you before the timeout? Do you do any sort of everyone participating in what's about to happen pre-huddle, and everyone talks about their roles and exactly what's going to happen? Do you do anything like that?
It's funny. Happens is everybody is brought into the room. There's an introduction. How it goes about. There's an introduction of who everybody is, what team they're a part of, and what their role is in the play. Then there's a message from usually the family or the organ procurement organization that talks about the gift and that who the person is that's giving the gift, and then there's an official timeout of what we're going to do. So it's very regimented.
Yeah.
I just think that it's literally people have gone through the motions so many times of a different type that this is so new, and that at times they're caught off guard. Now I will say that we've gotten some repeat kidney docs and some repeat liver docs that are out there either harvesting for their own organization or they're just a locum harvester. The repeat people, they already know what's coming, and they get it. So there's a couple guys in Kentucky that when we see them, we already know it's gonna go flawlessly. So it's not so much that this is a concept that's difficult to grasp. It's a little bit of thinking outside the box the very first time, and it's hard to explain what's going to happen. it's not hard to explain. It's hard to grasp the concept, it seems, until you see it, and then all of a sudden it seems like the light bulb goes on. I did comment that all this blood and this lack of hemostasis, we don't have traditional pump suckers.
Right.
So it's going straight to the door knock or whatever suction, major suction device. So that's why I almost have we comment out loud. Hey, we kind of watch those lines and we see frank blood going through. Like, hey, is there any way we can cut down on that? We need that volume back, or and so we make comments to our cardiac surgeon who tries to it has a peer-to-peer relationship at the table. So we have some cues that we give to our surgeons that we know that are buzzwords for them to look left and right after the traditional cannulation. Because really the hardest part is getting on the NRP device, and then once everything is stayed, cannulas are sewn in, it's really the dissection part that is the most difficult after that for all the other organs. And so they're kind of, the cardiac surgeon's kind of at the table just checking things out, really step to the side a little bit, but they're kind of our eyes and our suggestions at the table.
Gotcha. That makes a lot of sense.
Yeah, it does.
Well, should we get to the second slide?
Sure.
Slide? Sure. So these are 2020 results. The highlights are we did 125 adult heart transplants in calendar year 2020. We went on 21 dry runs that did not produce a heart. As you can see, 6 of them were our normal cold storage. 8 of them were our DCD transmedics. 2 were our expand transmedics, and then we did 5 of our NRPs that did not. We went out, did this traditional NRP, and the organ was not good at the location. We have not brought an organ back from DCD that we did not implant. So all 5 were aborted at the level of the hospital we were going to see. So that's what I'll touch on there. We did do, just as an aside, we did do a 1 en blanc. We did a heart and lung transplant that is included in those numbers. So 124 single heart transplants, and then 1 heart lung transplant in that. And so that 1 is in that 99 of your cold storage. But you, as far as percentage-wise, in 2020, very small percentage of about 20% of non-traditional. And then as far as this slide, you can see, with the expand, you can see that what is important that I see is that you look at the traveled mileage using the OCS. It's double or at least it's triple sometimes, and at least 1.5 times the length of travel you can do. You're looking at an average of 1,400 miles in the one category, and almost 850, or I'm sorry, almost 900 in the other.
Yeah, that's a big difference, because that's a long trip, even at 500 miles an hour.
Yeah, exactly right. And so, and our dry runs, were even longer, smaller end number, but using the transmedics device does let you reach out further. There's no question about it. And so that's the kind of thing that highlights on this slide. The other thing I will say is that if you look at the AM cases and the PM cases, it's really a wash when it comes to the traditional heart transplants. But I think it's because of the length of time that it takes to do some of the DC or NRP or this slide says Ecmo Dcd. We usually like to start those cases in the morning, just because the amount of time that it takes, the coordination. You do have to pump you pump the organs in vivo for an hour. It's a very very long time that it takes to actually do those cases. And I think we're getting better at it, but you can tell that the DCD cases and the non-traditional, what I call non-traditional, are much longer if you look at the case hours, how long it's taken to do those cases.
Mm-hmm. Mm-hmm.
So we can go to the next slide, 2021 results. And so I'm pretty proud of this slide. Our case volume really hasn't dipped. We're 11 months in, and we've done 115. Of that 115, we've done another en blanc. So one of those is a heart lung. So we're down to 114, if you will, single organ transplants. But more importantly, I think this slide actually shows what impact the NRP has had on us. Even through COVID related, hiccups in 2021, we're nearly a quarter is just DCD, and we've really, when it comes down to it, we're almost a third to 40% of what our total volume is non-traditional. So
Wow.
we've almost doubled
Wow.
what our non-traditional was from last year. The length of time and the mileage is roughly the same. Nothing has changed as far as the metrics, as far as the demographics, where we go, how long it takes, AM versus PM cases. But it's the ability to go out and really recover these organs that, for all intents and purposes, would be lost without an effort. I don't want to be crass about it, but these organs would be wasted, and we've actually taken 32 patients have an organ that they would not have received as soon. I don't like to say they wouldn't have received it, because they are on the list.
But they wouldn't have received this organ.
Right.
That's correct.
These 32 organs would have been.
Right, and Dr. Hoffman has a fantastic paper that was just published, that the results are astounding on these hearts. Primarily because they are younger people. There's no question about it. But these are organs that would have been wasted had not this therapy been introduced or implemented. Mm-hmm. And so the opportunity there, I think it shows that there are organs out there that traditionally would be wasted, that are fantastic organs that people need organs. And so the list is lengthy, and the wait is long. Mm-hmm. So I think this really highlights in a direction that it really, for me, it's one of those things. It's an aha moment in your career that you go, this is worth the long trips, the late nights, and the kind of the chaotic schedule of putting it together. And so the other thing I'll comment about, it takes 4 perfusionists at VUMC to do one of these cases.
Wow.
We send 2 perfusionists out in the field to recover the hearts. We have 1 perfusionist back in the hospital taking care of the recipient, and then of course you have the on-call person that is on call for any emergency. So if you want to say it's 3, that's fine, but it takes a minimum of 4 people at your hospital to pull off one of these procedures. So it is not not a labor-intensive thing.
Yeah, it's 4 people, because you can say, like you said, you could say 3, but you're a big major university hospital. You could have, if you only had 3 and something else comes through the door, they can't be sacrificed. So yeah, you have to take care of whatever comes through the door on top of it.
And I'll take it one step further. There's an organization that spent a lot of money and a lot of time, and I helped them, and Dr. Shaw helped them to try to get up and running on this. And they were a major ECMO center as well. And so you add ECMO onto that. So now you've got 5 people that are involved, because you have to have an on-call person and one person that's taking care of all your ECMO patients in-house. Well, they only had 6 staff members.
Wow.
Wow.
And they realized that the amplitude of actually adding 30 cases, or even if they, and they were a major transplant center, of adding 30 cases, even if you wanted to go 50 cases as a reach, that didn't justify them adding another FTE. And so they abandoned the program right away when they realized that they could not trim it down any further to get this. And so they spent a little bit of money buying some disposables, a lot of money buying a piece of capital equipment, a lot of time and effort getting the infrastructure right, only to know after 3 months they're like, this is not tenable. And so it's I think people underestimate the difficulty of saying that the procedure is really easy. I mean, it's not a difficult procedure, but the organization and the commitment to structure and to manpower it seems underwhelming at first. When you really get into it, it is daunting.
Yeah, it sounds like it. So, do you have any more slides?
Nope, that's it.
Good deal, good deal. Okay, so good. So, do you want to go? I've got questions, but you want to go first?
I just had one comment. The last thing you were saying about the program, that the institution that wanted to start this as a program, I think it's an interesting thing to talk about, that, they found the money for the capital, a piece of equipment, and the disposables, and contacting, the appropriate people to get the support to get it in place, but really didn't consider the manpower cost. I think that's something that we're very familiar with right now, just with what we're coming out of, with the same thing with ECMO. We had hospitals that wanted to start ECMO programs, but really didn't. But our established places that did have ECMO, pretty frequently, went from pretty frequently to all the time, and they did not consider what that was going to do to manpower from our side, from the nursing, even the intensivists, who you're spending a lot more time with these patients. And I think it was really a rude awakening to what that really is, the manpower cost and the resource utilization. So
yes.
So although I'm sure that institution is disappointed that they weren't able to do this at this time, it really shows that they're pretty smart in that they were looking at that and seeing what it was going to take to pull it off. So.
Well, that's a very good point. Which I guess I have several questions, but based on the technology as you see it currently, do you see the potential for more international transfer of these organs to expand it even farther than what you currently are, both with the traditional DCD and then with the with the transmedics rather, and then also with the DCD reconditioning with ECMO and then DCD. So I guess it's what you call your expanded model. Do you see, how far away do you see this actually getting?
Well, I'll just answer the question quick. We did get a call to go to Anchorage, Alaska, and that's a 7-hour flight. And our OPO, the OPO there, said we know you guys can do this, and it was very early on. I think we had 3 under our belt for the OCS, and we just felt that was really too much of a reach. I think if we got the call today, we wouldn't think twice about it. I will say, because of the geographic area, the Australians have really are leading the way in this, only because of the geographic necessity that they have in that country. You know, and they're partnered with New Zealand, so I don't want to leave the Kiwis out either. The 14 hours is what they've done.
Wow.
And so on the OCS box.
Yes.
And so to your point, Joe, I think it's more. I don't think it's going to be unless they get into until there's a world organization of organ donation, and I don't know. I'm not familiar with what's going on internationally, but I don't know if there's a sharing of organs in Europe from country to country. I don't know enough about that, but I can only imagine that if there was, to your point, there would be an international list by region, and just say, you know, we have a 34-year-old person in Portugal that is first on the list for, and you can, when you think about this, you know, to the HLA, to where no one would actually have to have a mismatched organ, size, HLA, and blood type would all be within, you know, almost within a parameter that you could really tighten up the window and just say that, you know, we have so many organs like this, or not, we have so many organs that we don't have to take a marginal match for someone, whether it be size, HLA testing, or what. Really, that's pie in the sky, that's future. But I think it could be started here in the U.S. just because of the geographic area that we have and the population that we have.
Yeah.
I think we would lead the way in that, or could lead the way in that.
Yes, very interesting. The other question that I had then is, what is your view on, since you brought up this hospital that there was also a transplant center, but decided that they wanted to expand into this OCS, DCD, transmedics, all of this stuff. What is your view on centralization? Because this can go from something as intense as this all the way down to just normal heart surgery, where you have some places that require a certificate of need, for example, before you can open up a heart surgery program, because they don't want, you know, outcomes are generally considered better at programs, and I mean, I think the data supports that. Your outcomes are better the more of something that you do. And if you do 20, 30, 40, even 50 hearts a year, your outcomes tend to not be nearly as good as a place that does 200 or 300 or 150 or 500 or whatever it may be. Do you see the same thing with this? So you get the heart there, but then your patient, actually the recipient, has to get the organ put in them, but then they also have to be recovered, and hiccups that may happen have to be dealt with. And when you don't have the experience with hiccups, then you may not be able to get that patient through that problem where someplace else they may have. So I'd like to know your views on, both you and Joey, on the concept of centralization when it comes to these very significantly advanced techniques.
Well, I will say that, you know, that you're exactly right that, you know, data suggests that, you know, organizations or hospitals that do more volumes have better outcomes. And, you know, I don't think that's a tough stretch to visualize it. Practice makes perfect. And you are constantly tweaking, you know, problems, and if you do enough, you'll see a lot of problems, and you're prepared for those a little bit better. As far as this particular, you know, therapy is concerned, you know, there is a lot. I was surprised to see the number of transplant centers in the country, and there's places doing, you know, in the teens. There's a lot of places that are doing the teens and 20s.
Really?
And you know, when you say well, you're doing one a month, you know, that's, you know, it's impressive that that you can have that level of results with such a low end, in my opinion. What I guess what I would say is that they may be very selective about what they're doing as far as what patients they're doing, because you do. I mean, I think your accreditation is based on your results in transplantation, if I'm not mistaken. I think you can lose your accreditation. I guess it's my point. There has to be some level of competency and results to pull that off. I will say that I think we have grown into a transplant center. I mean, it's tough to say otherwise, but in town, St. Thomas is a transplant center too. It's 2 miles down the road, and they're doing 20 to 30. And so to say that you can't have multiple programs in the same city that are very successful, that's definitely not true. To say that they're not doing a good job down the road, that's not true either. They're doing a fantastic job. I don't know where that cutoff is to say that we, as a team, as a hospital, shouldn't be doing these anymore because of the low variability. I think more importantly, it's having patients dual listed at multiple centers locally is probably the best suggestion. I know that's cats and dogs playing together, because that's having hospitals having two patients, or having the same patient be on a list of competing organizations. But on the same token, if we all step back and go that it's all about the patient, that's really what organizations should be doing. I think and that's my opinion. And if everybody is doing an adequate job to keep their accreditation and doing the right thing by patients, everybody, regionally, people should be on multiple different lists at multiple different centers, and say, this is what's best for overall humanity.
Very good. Well, I think that seems reasonable. I mean, I think that's fair, and I think you're 100% correct. Joey, I have a question for you, because you're so quiet.
Yes, sir.
None of us can get a word in edgewise. You're always right there. Where do you see this all going? What is your brain telling you as far as xenotransplantation, organ availability, expansion into this, where do you see heart failure maybe in the future? Do you see this as being a continued need at the current level? Do you see it becoming an increased need? So, sort of your overall views of all of where this is all going to end up in, say, 5 or 10 years.
Yeah, no, that's a great question. We've talked about kind of, not just what we're doing now, but ways to, one, improve what we're doing, and also figuring out what else we could do to expand the donor pool, and get those, potential organs that are maybe outside of our parameters that we've set right now. I think we do generally go for younger hearts at this point. Do we expand the age group? Hearts that are a little bit more marginal. Is there different techniques that we can do, in situ that when we're there, that could potentially result in an increased number of hearts. The xenotransplant kind of stuff. Me personally, I don't know. That may be way down the road. I have no idea. I don't know enough about it. The concept is a little weird to me, but I know they're doing research on it, so we'll see what comes of it. The heart in the box, the transmedics really open the door for a lot of centers, and And I wanted to say, what we talked about earlier is having the manpower to do this. I think really it plays a crucial role. And so you'll find a lot of the larger transplant centers, on East and West Coast, maybe, a couple sprinkled in through Mid-America that can handle this. So we may see patients brought in from other centers to, these bigger institutions to be able to handle that, this type deal, and then, recover there for a little bit. I'm not really sure how that works, from a logistical standpoint, but, it goes without saying that, the list, is definitely, outgrowing, the demand is outgrowing the, what we have.
Mm-hmm.
So,
demand is higher than supply. Yeah.
Right.
Yes. Sorry. Yeah. So, it, I think it's going to take some pushing of the envelope, taking some adventured risk, and that's that's the nature of cardiac surgery. You think about where we've come from the 50s to where we are now, and that just the amount of research that has gone into this, there's all kinds of stuff that's on the horizon, and I think we're excited to be a front runner in it, and they will continue to push forward and see what happens.
Those are very thoughtful comments, Joey. Thank you very much. Did you have any other questions?
I didn't.
I had one other question, Joey, and this is either of you can answer this. So I'm still very caught up on the idea that you're putting this patient on ECMO. I remember the video that you did the last program, which was very impressive with when it was go time and the saw didn't work and the speed in which you were trying to reinitiate circulation. Do you guys spend any time at that point where you just are trying to accomplish the highest flow that you possibly can before anybody touches the patient, and giving, very luxurious, let's say, DO2, getting all of the physiology straight, managing the acidosis, all of that stuff to where you get homeostatic neutrality long enough before everybody jumps in there and starts trying to pull their organs out?
Yeah, so if I'm understanding the question correctly, if there's some, I guess, hold up there and it not going smoothly, I think number one is our heart surgeon always tells the other, recovering surgeons to go ahead and make incisions and be on the ready in case we have to, kind of cancel the heart portion. And then it turns into a traditional DCD procurement for liver, pancreas, whatever abdominal organ that they're there to get. So that way there is, maybe just, how long does it usually take to get on? Like three, 4 minutes, And so if we're not on within those few minutes, there's no hesitation in our heart surgeon backs away, says go ahead, and that way, we're not sacrificing any abdominal organs, because that's the last thing we want. Now, I think back to your question, if I remember or if I'm understanding, if there's some issue, and we're just having like low flow, cannulas are in, but maybe not quite secure to the point where we don't want to, get all the way up to 4.5, 5 liters of flow. I think correcting acidosis is a top priority. It's not going to return back to a normal pH there, that 7.35 to 7.45. It's not going to get anywhere near that. Not right away at least. We have the sweep up pretty high to try to mitigate that, and then sodium bicarbonate to try to help it as well. The lactate's going to be pretty high, given the fact that the heart obviously is not perfusing for several minutes. So, Yeah, I mean, not quite. I mean, yeah, I mean they make some 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 adjustments, I suppose, to make sure that we can get out of that hole.
Mm-hmm.
I think actually the most important thing is that, and we've recently done this, is that the old adage, low flow is better than no flow, high flow is better than low flow.
Mm-hmm.
In the beginning, we were trying to reverse acidosis and get perfusion right away. We want to go on 4 or 5 liters a minute instantly. Well, these cannulas aren't secured in. There's no purse strings. They're just being held in by the junior faculty or the fellow or the resident that's with us, the second set of hands at the table.
Mm-hmm.
And so, we've actually started to just go at 2.5 to 3 liters of flow beginning. We've got a sweep of 10. We have the same 5 or 6 people of our group go, and we get a pre-op blood gas, what it looks like before the patient is withdrawn upon. So we have a snapshot of what the perfusates in vivo was before the withdrawal. And then as you get better, as you do more of these, you kind of have an idea. Well, for the length of time that the patient was dying, and until we get on, we have a pretty good understanding of exactly what pharmacological intervention, whether it be bicarb or other interventions that we would have to get back as soon as possible to that normal pH, to that homeostasis, that sweet spot, if you will. But to Joey's point, you could flow 5 liters a minute right out the gate, and it's still going to take 10 to 15 minutes to turn everything around. So in the best interest of everything, what we've decided is we're going to start off at lower flows, 2 to 3 liters a minute, until the cannulas actually get fixed in, and then we can go to 5 liters. Mm-hmm. And because in the big picture, if we go to 5 liters while the cannula's not sewn in, and all of a sudden there's either there's somebody gets bumped at the field or whatever, and that aortic cannula comes out, which it has before, or it just bumps up a little bit and delaminates the aorta, and we have a dissection, that heart's ruined.
Yes.
And so it's really, we've progressed into these things that we realize that slow, steady, almost like direct and specific motion is better than ragtag and let's just go, because there is a percentage of organs that you'll lose with dissections, and in the beginning it wasn't, our percentage was about 20% we were losing those organs, and then we realized where our mistakes were as a team, and it's us back there probably wanting to overflow, the surgeon up there trying to keep the cannulas in. It's a team effort.
Yes.
And so we have in quite some time now.
I'll say real quick, I think we've also it's kind of dawned on me. I think the biggest thing is reanimation and the return of coronary perfusion. We don't necessarily have to get all the way up to 5 liters of flow to get that. I think it's just the reperfusion itself that kind of helps reanimate that heart, and then it's beating, perfusing the coronaries is what's important for that that myocardium, and it doesn't flows of that high don't necessarily have to don't have to be immediate. It's just like Matt said, low flow is better than no flow. So we get some perfusion in there, heart reanimates, you're perfusing the myocardium. That's the number one goal up front.
Yes, yeah, that makes a lot of sense. What do you so you give the medications that you give for, because of course I'm assuming you're very concerned about reactive oxygen species, and you're concerned about that type of reperfusion injury that you're going to have with the oxygen radicals and all that kind of stuff. And so do you use the medications you use for scavenging those, or what's your process there?
Well, it's funny you asked that. That was one of the other things that we broke away from Transmedics. I think it's because of the length of time, but we use acetylcysteine actually.
Okay.
Mucomist, but you know the IV form of it in our prime, and so we're using mannitol, which is an oxygen-free radical scavenger. Acetylcysteine does the same thing, and so we are very conscious of that. Once again, because in the limited amount of equipment we can take, just to be mobile and not to, there's different air, I guess, connections in multiple different hospitals. So we don't even take a blender. We go right off of the valve, off the anesthesia machine. We're using 100% oxygen off the valve, and so we're not monitoring, or we're monitoring, but we can't do anything about. We can't do anything about, the O2 levels. We're 100% oxygen.
Mm-hmm. Yeah, that's because I've read a lot about that, where it's when you have a reestablishment of flow, it's the oxygen that causes all of your problems,
right.
But it's the oxygen that you're going to have. So you're almost really you're really in a difficult situation. But it sounds interesting that you're using the oxygen scavenging methodology in order to try and at least attenuate that, and it seems to be working, right? So your hearts are coming back and able to function and so forth. So that's a good thing.
Yeah.
Anything else? Go ahead.
I just have one more comment. I wanted to talk Tammy's very first question about staffing.
Yeah.
Of that, things. It kind of hit me up. Today, Joe, in this most perfusionists, I want to say, are either salary based or they're event based. I think event based are probably more local, smaller hospitals, but for the most part, I think larger organizations are salary based, not hourly, but just salary. And when you think about that model as a salary based, to have a hospital or organization say, hey, we're going to go ahead and do this. The only way people make more money in a salaried environment is if they work less.
Right.
That's right.
Right.
Or you increase their salary.
Yes.
I mean, that's the two ways. But if a hospital or organization was going to say, we're going to go ahead and adopt this policy, then we're going to try these new things, and we're going to do 10 the first year. So you just added 20 more FTEs on one of the slides. It was 11 hours to go do one of these things. So you just added, 20 more people to do 11 more hours per event, and there was no increase in their salary.
Right.
More than likely.
Right.
Right.
And so, from a perfusion standpoint, although this is a very attractive thing to grow your numbers, 10, 20, 30, 50 of these events isn't going to move the needle to get an FTE.
Right.
So that's the other obstacle I will suggest, that it's really a hard sell. If people are going to come to the perfusion department and go, hey, we're going to go do these random things 10 to 30 times a year, that is going to be very high intensive, and by the way, we're not sure if we can pay you more about this, but we're going to see what we can do. That's not very appealing to a perfusion group, in my opinion.
Well, it's not just the additional. Sorry, Matt. I was going to say it's not even just the additional hours. It's all the things that go with it: the travel, the obviously more unplanned events that you have to respond to. So
the stress.
Yeah, the
stress alone. You don't get paid enough for the stress you go through. Okay, because I'm going to tell you right now, they couldn't afford me if they wanted me to go do what you guys are doing. I'm not doing it.
It seems incredibly exciting, But living it out, I'm sure it translates a little differently many times. You know, it's inconvenient when these things are going to happen, even more so than what we are already used to with, you know, the standard emergencies and overnight cases and things like that. So I think you're right. There's really not, there's almost not a way to, unless you're really going to do a lot and really grow your team to be able to absorb that. I just don't see how it's attractive at all, other than just the actual experience of doing it. I mean, I would be thrilled to do it. I don't know if that's the life I want to live, though.
No, I would love to go on some ride-alongs with you and watch it. Okay, I don't know that I'm, you know, I mean, I'm kind of old in my career now. I'm not sure that that's a young man. It seems more like a young man's game to me.
Yeah.
But you know, when I look, I run, you know, as you well, you run a department, I run a business, and you have time? You good?
Yeah, I'm just making sure we're not getting kicked out of this room.
Oh.
Okay.
No, go ahead.
So Joey, I'll talk with you about this. I think you can now. Matt runs a department, obviously, and I run a business, and so the goal of a business or a department head is to get the most amount of work out of people for the least amount of money. And the goal of the either staff member, team member, employee, it doesn't matter how you want to call them, is to get the most amount of money for the least amount of work. And somewhere between those two edges is a good quality of life, good lifestyle, good, you know, work-life balance, good income, you know, what is acceptable to the payer and to the paid, and that's where you basically operate. If you're too far one direction or the other, you either have a failed business. Both directions you have a failed business. One, because you can't afford it. Two, the other direction, because nobody wants to work for you.
Yeah.
So there is, you know, we live in a free market society, and medicine is an industry. You know, so that's basically what you do. You try to get the most amount of work out of people for the least amount of money, and people are going to, you have to accept it. They're going to want to do the least amount of work for the most amount of money, and you basically just come out from the edges towards the middle, and you know, there's a gray area in there somewhere in the middle, and it fluctuates. But as you, if you want to have a successful business or a successful department, you have to have people that are happy with what they're doing, excited about their jobs, feel professionally challenged and with mobility, upward mobility in their careers, but also valued in terms of, it's not all I do in my life is work, although I work hard. You know, the more money you make, generally speaking, the more personal time you don't have. That's kind of goes hand in hand, I think. And medicine is a very, it's a commitment, it's a profession, it's not a job. So I think that all has to be taken into consideration. But people still want to have a personal life, and they want to feel rewarded, appreciated, respected, and compensated appropriately for what it is they have to do, the amount of time they have to spend, the sacrifice, and as you said, the stress involved with this. You know, you go get a heart, you know, you don't know any of these patients personally, but that heart may as well be going, that may as well be your family member's heart going into a family member at the other end that's going to be the recipient. There's a tremendous amount of emotional connection that takes place. We take our jobs very, very seriously. And, you know, I think, you know, you can make a lot more money catching a football because that's entertainment. But I think that as a whole, and I don't want to really belabor this, but I think our society as a whole has got it all screwed up in what we value and what people actually earn for what it is they do and the impact that has on people's lives. Whether a football game is won or lost is only going to matter to the odds makers in Las Vegas and the people that bet on the damn game, or people that are emotionally disturbed and it's the end of their life if their team didn't win the damn Super Bowl. But they think nothing about traveling 1,400 miles to go get a heart out of a patient in one of the most tragic events of that family's life, to take to somebody else who is praying like hell that that organ comes back in a healthy way so they can get on with their life. And all of this happens not in a vacuum. It happens during the holidays. It happens on their birthdays. It happens
during kids' activities.
Right.
Yeah.
So, I mean, but that's a big philosophical conversation, and I'm sorry for going off on this tangent, but it is fundamentally how I feel, that I think that as a whole, medical professionals, from the top physicians, surgeons, to the scrub techs that are handing the instruments up in the field, that matter tremendously with how they're doing their job, so that the surgeon can do their job, so that we can do our job to help the surgeon do their job. I just think that at the end of the day, all medical professionals are grossly underappreciated in our society. But there's my high horse, sorry.
Well, Joe, I appreciate today. We're actually getting booted out of this conference room.
Oh,
Are
yeah.
you really?
It's 8:05.
Yeah.
They're busy there at Vanderbilt.
Okay, well, you know what? Tell them their program can wait. This is more serious. Tell them Joe said. All right, we're going to take a,
All right.
Joey, Matt, thank you all very much.
Thank you so much.
We're going to take a quick 5-minute break, and Sparacino Journal Club. This is going to be a very interesting lecture. The title of it is Neurologic Recovery After 10 Minutes of Absent Cerebral Blood Flow at Normothermia, which sounds like a very crazy thing. I'm really interested in hearing this. I have not read the article, but I'm really interested to hear what happened here. So we'll be back in 5 minutes. Thanks. hello everyone. Welcome back to the program. That was really interesting from the Vanderbilt guys, their last program for 2021, and what they're doing. It's amazing. They're doing 12 heart transplants a month.
Yeah, so they did, what, 125 last year. They're up to 115 so far. I really
and they
liked.
still have another month to go.
Yeah, and I really liked how they kind of broke down into the 4 categories, the different ways that they do it, because they use a lot of terminology most people aren't really familiar with, and even though I've heard a few talks on it, having it summarized like that, I think was really helpful.
Very helpful, I think. And of course, we are here with our old friend John. John, have you been sick? Where have you been?
Hi, John.
No, I had a little surgery on my face, so I was kind of mangled a couple weeks ago. It's like I just couldn't make it, and it was actually happened on the day of the lecture. It was the only time I could go into surgery also.
Was it an accident?
What's that?
Was it an accident?
No, just having some skin cancers and stuff removed.
Well, good for you. I'm glad you did that, and you're doing well.
That's very common.
Yeah, I'm doing well,
That's
and it was a big thing they did, and you wouldn't want to see me on camera for about 3 weeks, so things are a little better now, though.
Well, I'm glad. I'm glad you're doing well. Well, you look good. You don't look any worse for wear. You're not any less attractive than you were before.
Yeah, well, when you hit rock bottom, there's nowhere to go, right, Joe?
Exactly. Nowhere but up, right? Exactly. Okay, so we are here with Tammy Sparacino sitting right next to me here in the studio, and, of course, John Ingram coming from Orlando. I'm assuming you're in Orlando. You may be in the Keys. I'm not sure. Orlando. And
I'm in Orlando today at my home that I bought back in May in Orlando, and you may hear a teeny bit of construction going on outside every now and then, but I don't think it'll be too much. So I'm glad to be back with you guys, and hey, you guys are looking good.
Thank you very much. Okay, so we're going to jump right into this lecture of Tammy Sparacino on. Yes.
Share that iPad.
Oh,
yeah.
Share the iPad. Scroll down.
Wait, hold on.
Nope.
Oh, hold on.
It's all right. I'll do it.
Well, that's good.
Well, you're already there, so yeah, I think you just have to do it a little harder.
Oh,
Joe's iMac,
there it is.
and then I'll come up here, and then we'll go to
Slideshow, right?
Yeah, slideshow. Presenter view.
Oh, presenter view, yeah. There we go.
Now we're good.
Are we good?
Got it?
Yeah.
Good.
Okay.
Okay, here we go.
Okay.
Neurologic recovery after 10 minutes of absence from blood flow at normothermia. Okay, where's this from?
Are you doing this or
No,
am I?
I'm sorry.
Oh, okay.
I'll let you go on.
Welcome, everyone. Today we are going to be looking at a case report that was published in the journal Perfusion mid last year, and the title of it is Neurologic Recovery After 10 Minutes of Absent Cerebral Blood Flow at Normothermia, with the main author being Pennell, and here we go. Let's get into it. Okay, so the abstract. Prolonged normothermic cardiac arrest is associated with high incidence of neurological morbidity and mortality. Whole body temperature controlled perfusion has been applied to limit reperfusion injury and minimize ischemia. We describe the full recovery of a patient after the application of rapid hypothermia following an intraoperative aortic rupture with 10 minutes of absent cerebral blood flow.
Okay, wait, don't go so fast.
Okay.
Full recovery. Rapid hypothermia. Okay.
Got it?
Mm-hmm.
All right. Okay, so we'll start with the patient information. So this was a 57-year-old male, obese, BMI 35, classification NYHA1, which means no limit of physical activity. And I'll get into those classifications on next slide. Let's just get through this part. Presented for a triple vessel cabbage. He had an anterior ST elevation MI, EF of 35%, anterior and posterior hypokinesis. Okay. And in case you're not familiar with the New York Heart Association classification of severity of heart failure, here it is for you. So this particular patient was class 1, meaning having no symptoms, normal physical activity, no functional status of note. And you can see as you progress down to class 2, it's mild symptoms. Symptoms include fatigue, palpitations, chest pain, dyspnea, and syncope. And class 3 would be moderate symptoms. Class 4 is severe symptoms with features of heart failure, even with minimal physical activity. Okay, so the initial procedure, cardiopulmonary bypass was initiated, temperature drift to 34 degrees Celsius, intermittent cold antegrade and retrograde blood cardioplegia going in at 4 degrees, single cross clamp 90 minutes. They did the Lima to LAD, radial artery to diagonal, saphenous vein to PDA. They rapidly weaned from CPB with no problems.
So a 3-vessel bypass with a 90-minute cross clamp time.
Correct. Okay, so their complication. At aortic decannulation, a transverse aortic arch rupture. The rupture extended beyond the double purse string snare, progressively posterior location, likely cause, number 1, they noted high systolic pressure of 145. Likely cause number 2 is a fractured snare tip. Okay, so then they had to initiate their second part of the procedure. The patient was exsanguinated into the pump reservoir. The aortic cannula inserted with a non-pledgeted single purse string around the ruptured aortic edges. 10 minutes of normothermic circulatory arrest. Cardiopulmonary bypass flow was re-established. They did a rapid cooling to 18 degrees Celsius. Parts of the controlled reperfusion of whole body was instituted, and we'll get into what that actually is momentarily. Okay, so their reference for this case presentation and also for our own education, in case you're not familiar with what's called the controlled reperfusion rewarming protocol, was published, this procedure was explained in this published article in the Journal of Thoracic Disease, published in 2019, and it's called Controlled Automated Reperfusion of Whole Body After Cardiac Arrest by Trummer and colleagues. We'll just briefly go through this just so we all kind of have an idea of what they're talking about. So the background abstract, sudden circulatory arrest requiring cardiopulmonary resuscitation has for decades been associated with high mortality and frequent neurological sequelae. How do you say that?
Sequelae.
I don't know why I can never remember that. Sequelae in rarer survivors. The high mortality and morbidity are potentially related to severe and global ischemia reperfusion injury, IRI, of the whole body, especially the brain. Consequently, strategies to counteract this severe IRI may improve survival and neurological recovery of affected patients.
You know, it's so funny. I don't mean to interrupt you, but this is basically what we just got through talking about with Vanderbilt, right?
I know.
It's
Isn't that funny?
It's the same concept.
Right. And I almost piped in on something, but because I'm not super familiar with it, I thought you and I could talk about it afterwards on some of the things that they do to try to reanimate the heart and what they do to protect it. But we'll get through this first, and then that can be a part of our discussion.
Yeah, the big difference is that's the heart. This is, of course, they're not concerned about the brain anymore.
Right.
It makes their job a little easier.
A little bit easier, yes. But some of the same principles apply, and I think it's actually was great timing for this case presentation
Yes.
following their talk. So just briefly, their methods, based on the target to limit IRI in single organs, suitable parameters and methods were composed to form a global treatment concept. It's called the CARL method, which is controlled automated reperfusion of the whole body. The concept centers on extracorporeal circulation enhanced with readily available online monitoring. It allows for targeted adaptation of different parameters like blood pressure, flow, temperature, oxygen content, and electrolytes during the reperfusion process. in the sense of controlled reperfusion. Parameters and elements of the Carl method were extensively tested in chronic animal models. An appropriate medical device, the system called CIRD 1.0, which is Controlled Integrated Resuscitation Device, is approved to be applied to patients. So that's the device that they use to measure all these different parameters, which we're not going to get too far into that. I just want to make sure everyone understands what this Carl method is, because it's applicable to our case presentation. So their results, a set of parameters that support limitation of global IRI has been identified in over 250 animal experiments. Their specific targets and surveillance using adequate monitoring features are described. Using the CIRD in a single center, 14 patients with witnessed but extremely prolonged CPR, 51 to 120 minutes, yeah, very long, have been treated with Carl. The outcome of these patients was favorable, with 7 of the 14 patients regaining full consciousness and 6 of the 7 allocated to cerebral performance class 1. So the conclusions, CA followed by CPR is associated with very high mortality and frequent neurological
Sequelae.
I don't know what my problem is.
It's okay.
Limiting the occurring severe and global IRI may be kept to an improved survival and neurological recovery. Therefore, the therapeutic approach of Carl, which stands for a personalized comprehensive therapy based on readily available set of monitoring data and diagnostic findings, have been developed. First experience in patients indicates the beneficial effects that call for further studies in the field of Carl. And they have just a couple graphics here. This is just the figure that they included talking about reperfusion and reperfusion injury. The description here says ischemia reperfusion energy, reperfusion injury figure. Interruption of blood flow to the cells causes a time-dependent cellular damage. Reinstitution of blood flow with regular blood flow, which is reperfusion, does not prevent further damage, you can see with the blue arrow, but is associated with the continuation of cellular damage, which is called reperfusion injury. In patients with sudden cardiac arrest, it is impossible to control ischemic damage. Therefore, the goal of the targeted algorithm of Carl is the reduction of the extent of reperfusion injury, which is the red field, of the whole body and the brain immediately to a survivable and recoverable extent. Carl, which is again controlled automated reperfusion of the whole body. And then they have a table here. It's kind of lengthy. I had to put it on 2 slides, but it talks about the different targeted control parameters. So if you'll look here, you'll see that the target for our arterial PO2 is 100 to 200. So you're going to limit those oxygen radicals. Your PCO2, 35 to 45 to support pH stat strategy. Your arterial pH is less than 7.25. And the pH stat strategy is in order to lower cellular metabolism during the first 30 minutes of reperfusion until substrates are replenished. You want an extremely high blood serum level of potassium greater than 6. That's to convert ventricular flutter fibrillation into asystole with subsequent minimized oxygen demand for the myocardium. Sodium level in the blood, 136 to 146, to avoid excessive alterations of serum sodium levels with respect to cerebral volume and displacements and subsequent cerebral edema. Calcium level in the blood, extremely low, less than or equal to 0.5 within the first 15 minutes of reperfusion, and that's for the prevention of cellular calcium uptake, thereby limiting cellular edema. And then pulsatile blood flow with the target of 60 to 80 mLs per minute per kilogram for body weight minute until pulsatile flow is generated by the patient. And that's for enhanced hemodynamic power to reopen capillary flow areas and counteract no reflow phenomenon, especially in the brain. Duration of the pulsatile flow up to 60 minutes. Okay, continuation of the same parameters. Mean arterial blood flow 80 to 100. That's also for enhanced hemodynamic power to open capillary flow areas and counteract no flow. Body hypothermia 32 to 33 at the core and as fast as possible, lowering your cellular oxygen demand. And then osmolality in the blood greater than 320, limitations of cerebral edema, and to decrease vasopressor requirements.
Mm-hmm.
So these are all the targeted algorithms of this method called CARL.
So really, it's not that deep a hypothermia. I thought you were going to go to 18 degrees or something.
Right, and that's kind of what this article looks at, is that the thinking was, and it's not that they don't cool, because we will get to that, you know, they do cool, but that you may not have to cool as long, and the way that you warm up is different, okay? Okay, back to our case presentation. So their technique, the PO2 was lowered to less than 150. Alkalosis was avoided. Calcium was kept low. Their target was 0.7. At 18 degrees, bypass was stopped for 6 minutes to insert a leukocyte depleting filter. They switched to a femoral cannula. There was an additional circ arrest for 8 minutes after a period of reperfusion for aortic debridement. Aorta repaired at 10% calculated full flow for the BSA for 9 minutes. The SVC was cannulated, 5 minutes of retrograde cerebral perfusion at 30% of full flow. The SVC was clamped. CPB was flow was stopped for 5 minutes to wash out debris or air from the aortic arch. During retrograde cerebral perfusion, high suction on the aortic root vent in Trendelenburg position, and then the patient was rewarmed. Osmolality was kept high but not measured, but this, how they increased it was 200 mLs of 25% albumin, 250 mLs of mannitol at 20%. The patient was warmed and weaned with 0.03 epinephrine. There was an uneventful course in the ICU, which they stayed for 4 days. Their temperature was kept below 36.5, but really it was just unmanaged. They were kept intubated for 36 hours, discharged on day 14 with no gross neurological deficit, and histology of the aorta revealed only plaque. All right, the author's final comments. It's kind of lengthy, so I'll just touch on a few things. They just talk about the role of post-cardiac arrest-induced hypothermia. It's a protective neurological strategy that has been investigated for a very long time, over 6 decades. Although the use of targeted temperature management, also known as TTM, has become a standard of care in the ICUs and resuscitation guidelines, there remains an equipoise, which means a thought process, right?
No, equipoise is I think agreement, or like, you know.
Right. In other words, this is kind of what's done on temperature and duration of this therapy.
The exact
on the target
definition is balance of forces or interests.
Okay, balance of forces or interest on the exact temperature and duration of this therapy. The International Liaison of Committee of Resuscitation, or ILCOR, initially recommended lower targeted temperatures of keeping the patient at 32 to 34 degrees. The data for which this hinged primarily on 2 clinical trials published back in 2002. These studies compared moderate TTM versus uncontrolled temperature management and confirmed an improved survival in the hypothermic treated shockable arrhythmia patients. More recently, however, the ILCOR recommendations have expanded the treatment range to 32 to 36, following a clinical trial that showed that lower temperature is not superior to the control of peak temperature below 36. Just a few more comments here. The strategies do, however, rely on an extended period of hypothermia, 12 to 28 hours, with slow rewarm of half a degree an hour. A subsequent animal study has shown that it may not be necessary for long duration cooling for neurological benefit. 30 minutes of cooling to approximately 33 degrees in conjunction with controlled automated reperfusion of the whole body following 20 minutes of normothermic cardiac arrest was sufficient to significantly improve survival and neurological outcome in a porcine model. In this clinical case that was just presented, the patient was rapidly cooled to a temperature of 18 degrees. The strategy was partially neuroprotective following normothermic arrest, as well as providing sufficient time to address the arch, as a full extent of the tear was not initially evident. It is not clear what optimum nadir temperature is, as there is no evidence to support deep over moderate hypothermia as a part of a post-arrest strategy. Our rewarming strategy of 11 degrees per hour far exceeded the less than 1 degree recommendations of the clinical studies. However, the potentially beneficial effects of slower rewarming on neurological recovery must be offset by the prolonged bypass time. Final thoughts here. Together with the hypothermic strategy, reperfusion injury was limited by including parts of the Carl strategy that could be implemented in this special case. For example, maintaining the normal PO2, aiming for low calcium, allowing time to reduce the free serum calcium. No calcium supplementation was given, which would have normally been their standard practice prior to weaning. They increased the osmolarity to limit cerebral edema, prevent alkalosis, and add a leukocyte filter to reduce free radical formation. Thus, radical short-term deep hypothermia with standard rewarming and applying parts of the reperfusion concept of Carl resulted in neurological recovery following 10 minutes of normothermic, no-flow cardiac arrest. Although it may appear futile to continue to support a patient following a catastrophic event as described, clinicians should consider the above described aggressive targeted strategy in a post-circulatory arrest. And that's it.
That's a lot to unpack.
It is. It's a lot.
So can you go back to one of your earlier slides?
Yep.
Like very early.
Okay. Which one? Case presentation, complication, initial procedure?
I don't know. I have to
we'll start here.
I have to go back. No, it was past that. Past that. Past that. Oh, wait, go back. Go back one. Okay, so hard for me to believe that a pressure of 145 caused this problem, number one. John, you got any thoughts?
Yeah, I got a lot of thoughts.
Got a lot of thoughts.
This is really, like you said, Joe, talk about a lot to unpack. At some point, guys, here before we get too far in the discussion, I'd like to, if we could, just spend about a minute going through the actual steps of everything, of the phases of the case here, of what happened. But I have always suspected, talking about this slide here, I have for many, many decades suspected, and I'm really surprised that we don't see more intimal tears of the aorta upon insertion of an aortic cannula. And I'm sure many years ago that I witnessed this and nobody knew what really was going on in the case, but this was the only thing I could figure out what was going on. But that's a story for another day. But I'm almost shocked that we don't tear intimas a lot more inserting these cannulas than what we appear to do. Mm-hmm. And all it would take is when the surgeon puts the purse strings in and makes that little incision into the aorta, then they quick dive the aortic cannula into the aorta. If they had not sliced all the way through the aorta and the intima did not get cut by the scalpel, then when you push that aortic cannula in, it then could push down or tear the intima. And I've always thought to myself how often this might happen, but I think that's what caused this in this case.
Mm-hmm.
Yeah, more than likely. It was already there. I don't think the high blood pressure, 145 is not a high
It's
blood
not that
pressure.
high, right.
So, from our perspective. But, I remember back in the old days when we put aortic cannulas in, they would put the purse string and then they would stab it with an 11 blade.
Yes.
And then we had this dilator, which, of course, started with a very small tapered tip and that would come up, and it was very round. It was metal, and they would take that. They'd take their finger, they'd put that in there, and they'd put that in very gently and dilate that hole, and then that would come out, and then the aortic cannula was put in, and the purse strings then with the snares to support it to stop the bleeding from around it. So the hole was actually made bigger than what the cannula was going to be by the dilator that they put in. It was kind of it was about that long, had a little curve to it, and it started off very small with a very rounded tip. It was metal, very smooth, and then just got wider as you went up it, and they would put that in. And, you know, we used to do it that way. Now I see them doing this kind of thing, and I'm like, man, I'll tell you what, you know, delaminate, you know, you can delaminate something doing that, you know, and just basically tear the intima off of the media, or the, you know, and cause a big problem. It doesn't take a lot.
When is the last time you saw them use that dilator? Because I don't think I've ever seen it.
Yeah.
I'd have to try to find it. I could probably find a picture of it, but I mean, it was, I mean, we're talking, you know, decades ago. It's been a while. You know, it was probably in the late 70s, early 80s, if I remember, you know, right? You know, it used to be, it was a popular device at that time.
Well, just like what you said, you witnessed it. You all have witnessed this many times where they stab the aorta, and then they just, you know, pretty much as quick as possible put that aortic cannula in there because it's squirting out. Now, I'm not a surgeon. I don't play one on TV, so they know what they're doing. But I've often thought to myself, with that, what looks to be a pretty, you know, rough insertion, that we could tear intimas, but apparently we get away with that, and they know what they're doing. But I've often thought it might not be that hard to tear an intima. So I'm a little leaning towards maybe that's what happened in this case.
Yeah, more than likely.
More than likely.
So, can we recap just the big phases of what happened here for the audience benefit and for my benefit? So we did a cabbage. We did a normal cabbage.
Hold on,
right?
let me get back. Okay.
So they did a normal 3-vessel cabbage.
Right.
Everything was fine. When they removed the cannula is when they noticed there was an aortic transverse arch dissection, right?
Right.
So then they had to go back on, which I assume they may have gone back on fem, or at least femoral artery.
Well, at first, no. They do convert to that. Okay, so it sounds, I don't know, they don't detail exactly how they achieved, let's see, get to this one, to the procedure, of how they achieved exsanguination. I don't know if the venous cannula was still in for some reason, or they were able to get it quickly back in. They don't talk about that, but they basically get all the blood, you know, out of the heart, as much out of the patient, and then so they can see where to put the cannula in.
So can you scroll back? Okay, so it says right here, and again, I didn't read the article, but it's in the bullet points.
Yeah.
So they were removing the aortic cannula. At aortic decannulation,
right,
there was a transverse aortic arch rupture, which I don't think it was a rupture. I don't even think that's couched properly, because if it was an aortic rupture, you would have blood everywhere.
Right,
it'd be a
it's
big
a tear.
disaster. So
but that's the word they
noticed
use.
a dissection.
Yeah.
Okay. The rupture extended beyond where their double purse strings were. It progressively went posteriorly. The likely cause, but then go to the next slide. The patient was exsanguinated into the pump reservoir. So what I'm assuming is they put the venous cannula back in, heparinized, put the venous cannula back in. And then aortic cannula was reinserted. It doesn't say reinserted, with non-pledgeted single purse string around the ruptured aortic edges. So they just probably went in. It looks like they went in through the same site, and God love them for getting into the native lumen, that they didn't go into the something else, but they got away with it. And then they just went to normothermic circulatory rest. So what doesn't make sense to me is they put the cannula in, and they drained the patient, but then they just sat there for 10 minutes?
No, they didn't just sit there. It took them 10 minutes to get the aortic
so there was 10
cannula.
minutes of that.
And
then they
it was
reestablished
established.
flow, and started cool.
Right.
Okay, so what? And then okay, so I got it.
So
Okay.
yeah, so they will eventually, John. Like what I was trying to say is, I don't know if for some reason the venous cannula was still in, or they quickly put it in after reheparinizing. Regardless, they got.
That comes out first, though. Normally,
Not
doesn't
always,
the
though.
venous come out first
Sure,
before you
but
get
not
frozen?
always. I've seen it the other way as
Really?
well.
Well,
But-
I think my guess would be they probably, the venous cannula was probably just still in. That wasn't the problem.
Right.
But either it was or not, they had. But I think most people take the aortic cannula out.
They do.
I don't know about most, but I've worked many places. You take the aortic cannula out, and then you feed blood back up through the venous line. I don't know how many places do that, but it's somewhat common. But regardless, what I'm trying to understand is, why would you put an aortic cannula right back into the dissection site?
But that's what they did. In fact,
So-
I'll read it to you real
Yeah,
quick from
okay.
the article. So they said, at aortic decannulation, a transverse aortic rupture extended beyond the double purse strings, progressively posterior, most likely due to what they told you. The patient was immediately heparinized. Additional tin was added to the pump reservoir. The patient was allowed to exsanguinate into the CPB reservoir until the aortic edges could be identified. An aortic cannula was inserted into the defect after a large non-pledgeted single purse string was sutured around the ruptured aortic edges. So that's exactly how they describe it. So it
So
sounds
is
like to
that
me
the
the venous
repair?
cannula must have still been in, but I don't know.
Yeah, I don't know.
Yeah.
So,
Whatever.
So is that the extent of the repair that they perform? So in other words, they exsanguinate the patient, and then they go back on just to do then they do a normothermic circulatory arrest to repair the dissection.
Well, no, I think it was just to get back on, and then once they reestablished the flow, they started cooling. Then they started doing the part of the Carl protocol. You know, they started adjusting some parameters, and we'll get through that.
Yeah, they
real quick.
repaired it, John, because they
Yeah.
did retrograde cerebral.
Yeah.
So they more
Okay.
than likely did a hemiarch.
Yeah.
I'm assuming.
Yeah, right.
Right. And so let's see. Yeah, they just don't go into detail what's done. They just tell you, the
They
SVC.
repaired it.
Yeah, it was repaired. I guess that wasn't the focus of this, but
Right.
it was repaired. And you can see here that on this slide that they then, after once they were at 18 degrees, then they switched to a femoral cannula.
Okay. So they wanted to get that aortic cannula in as fast as possible, so they could cool as fast as possible, because
Right.
they crash cooled back in the
Yeah.
old days. We call it
Yeah.
crash cool. And then they only needed, well, they did 10 minutes of circulatory arrest, but then they did retrograde cerebral perfusion. So, I mean, I'm not sure how long this repair took, but maybe it's not significant since
Yeah.
they were doing retrograde cerebral perfusion anyway.
Yeah, maybe not.
Well, what's amazing to me is they had to stop CPB for 6 minutes to insert a leukocyte depleting filter. That's an awfully long time to have to insert a leukocyte depleting filter.
Right, and
6 minutes, but at 18 degrees you can get away with
you
it.
can get away with
But
it,
of course
right?
you've already had issues,
Right.
going on.
They probably sent the student or assistant perfusionist
To go get it when?
Closet somewhere, couldn't find it.
Yeah, exactly. So there is one note here. I'll read this to you, John. The aorta was primarily repaired in a double layer at 10% of calculated full CPB flow per body surface area. And that took 9 minutes is what it said. Yeah.
So they may have just.
So,
I guess they could have oversewn it. I don't know
yeah,
what
I don't
they
know,
did.
because
I'm
they
not a
don't
sur-
they don't talk
I'm-
about putting a graft in or
I'm
anything.
not a surgeon, so I don't know what
I don't know.
the hell you do for this.
So we crash cooled to 18, and we managed some type of repair with some retrograde cerebral perfusion at 18 degrees, right? When the circulatory arrest times don't sound very long. I mean,
No.
they were 6 minutes and 8 minutes.
What?
And apparently they were pretty slow at putting grafts on, but pretty quick at repairing the aortic.
Right. So I think the main concern would be the first circulatory arrest, the unplanned one of 10 minutes of getting.
The point is they went 10 minutes
in the beginning
of no flow
normothermic,
at normothermia, which probably really wasn't totally normothermic, because you're in the operating room, you just finished bypass, you're likely not going to be at 37.5 or 38 degrees. So, you know, and you're going to cool quickly. The room is cold.
Yeah.
You know, there's all that stuff that goes on. So they probably really weren't totally normothermic.
Yeah.
But, you know, there still were, you know, certainly 10 minutes
Yeah.
in that
Well,
circumstance
and they do make
was a while.
they do.
It's a lot.
There's one statement that I thought was interesting to just include. It said all timed events. So in other words, I guess, you know, where they're getting all these minutes were captured by the anesthetic resident. That's what it says.
Okay.
So there was somebody who was on this, you know, that was their
only job.
That was their job,
Right.
was timing all the things.
Right.
So,
Right.
yeah.
Right. Okay, so I want to see something else. So, so
John,
can
did you have something else on this, or can I move on?
Well, so then the next thing that they do is they
Right there.
begin to rewarm. Let's say they've done the 18 degrees,
Mhm.
the repair is done. Now they begin to rewarm, correctly?
Yeah.
Correct?
Mm-hmm.
And how fast do they rewarm? Because there was a couple different things that they said there. They rewarm at
11 degrees per hour.
Right. So you can divide that by 60 and you'll get your how much per minute.
Yeah.
but if you're at 18 and you have to get to 37, that's roughly, 19 degrees. So it took them almost 2 hours to
Right,
rewarm.
but I don't think they went to 37. They talk
Well,
about that. Let's see.
So they stop at 34 to 33, 33 to 34. They stop there and exercise their Carl technique, it sounded like,
Yeah.
for a period of 30 minutes or something.
Correct. Let me get to that. Let's see. Patient uneventful course, strategies in this clinical case. The strategy, partial neuro. Hold on just a second. Okay, so our rewarming strategy was 11 degrees Celsius per hour.
That's about 1.8 degrees per 10 minutes.
Yeah.
Block of
Well,
time.
an hour later, you're at 29 degrees, so you're still pretty
Well,
cool.
but hold on. Let me get to another slide here because I don't know where it is exactly in the article, but so yeah, I guess you're right because they talk about patient rewarmed here, but I didn't know if there was a notation that they rewarmed at at 11 degrees per hour and then went to a faster warming, but I don't see anything about that here. So
They actually did talk about that. So if you go towards the end of your slides, so don't go so fast though. Okay. It was in your comments.
oh, the comments section, yeah, because I read it was so lengthy I couldn't summarize it all.
So
This is all just standards, so it's not that one.
Okay, here you go. Stop. This something's in there. Okay, so they talk about the nadir temperature being, there's debate about that.
Yeah.
So our rewarming strategy of 11 degrees per hour far exceeded the less than 1 degree centigrade recommendations of clinical studies.
Right.
So actually they were saying they rewarmed
much faster. Yes.
Than what is considered acceptable by the standards.
Yes.
And
well, that's in cases of people coming into the ER for accidental hypothermia.
Exactly. I was going to say it doesn't actually apply to this.
Mm-hmm. Yeah, that's greater than less than 1 degree per hour. So like 0.5 degrees per hour you do when you're going from therapeutic hypothermia back to normothermia. But I don't think this is the same thing.
And let me ask you something. I mean, we do circulatory arrest cases, sure, but not. Sometimes we aren't we are not going as low as 18 degrees. It's going to be a short repair or whatever the case may be. But back when I used to do those sorts of cases, it's been quite a long time ago. Thought what we were to do was to not have more than a 10-degree gradient, and that was how you judged how fast you could warm, right? They don't really mention that too much in here, but the process can be kind of slow, especially on larger patients, right? Having that having to follow that gradient recommendation. But that's really all as far as timing that is usually discussed in that. Is that correct? as far as how fast you can.
Yes,
Yes.
your gradient is a big thing, right?
Is your guide, right?
And of course, the smaller your patient, that same gradient for a patient who weighs 55 kilos versus a patient that weighs 155 kilos
quite different.
is going to be very, very different.
Right.
And then not allowing the perfusate temperature going to the brain to exceed 37 degrees.
Right.
And I guess there's some debate about it staying 36.5 versus 37.
I even saw 36 in here somewhere, but yeah.
Yeah, but you want to make sure that you don't rewarm too rapidly, but that's really for more neurologic protection than it is anything else. I believe, and so and I think that's really what it comes down to. The brain's very sensitive to that, and if you have injury, you will exacerbate an ischemic event. Let's say if you have an ischemic episode of the brain for whatever reason, air, debris, it doesn't make any difference, and you rewarm either too quickly or, more importantly, from what I understand, you exceed a certain temperature, you will exacerbate that injury and have far more problems than if that one injury was left as it was.
Well, I think while we're on this slide, I wanted to bring this up real quick, and then I'll give it back to you, John, because I know you had some additional comments. But there one statement here of talking about a subsequent animal study shown that it may not be necessary for long duration cooling for neurological benefit. And here's the part I want to highlight. 30 minutes of cooling to approximately 33 degrees, which is kind of just normal drift temperature, right? But get there quickly. In conjunction with the Carl method, following 20 minutes of normothermic cardiac arrest was sufficient to significantly improve survival and neurological outcome in the pig model, which is pretty interesting because that's a lot less cooling.
So in other words, if you had somebody who had 20, or in this case it was animals, 20 minutes of cardiac arrest, which I don't know if they mean CPR as well, but anyway, then the therapy becomes cooling to only 33 degrees and then implementing this complete Carl protocol, which is pulsatile flow and PO2s between 100 and 200, all the things, pH,
calcium, sodium monitoring, all that, high potassium.
Yeah, all this stuff. So, the whole dilemma about reperfusion injury, I've looked into this and written some things on this in the past, and the cruel reality is that the ischemic damage is occurring because of lack of oxygen, and the one thing you need the most is to reinstitute oxygenated blood flow, and as soon as you do that, the vital thing that you need causes actually more severe injury on some levels than the actual ischemic injury that is happening to itself. And one of the reasons, there's multiple, but one of the reasons is that the oxygen itself becomes such highly free radicalized that the free radical injury is a huge part of the reperfusion injury that goes on. And I know that's why they're saying to keep the PO2 low between 100 and 200. I'm surprised they don't actually constrict it down more to like 100 to 120 or something. But the very thing you need the most causes the damage at the end of the day as well. So that's interesting.
Well, you have other organs, right? But here's the thing. You have not just the brain is obviously the most sensitive, but you still have other organs.
Yeah.
And if you look at the ACLS protocols that currently exist, if you go across find a patient who has witnessed cardiac arrest, you don't even breathe for them. It's flow more than it is your oxygen level, right?
Yeah.
So as long as you have flow, even if your PO2 were 50, and we've seen this with our ECMO patients with PO2s of 50, talking to us.
Conscious, making sense.
Yes, if you have flow, that's what's important.
Well, I think
so
that's the whole
I don't
point
even know
here.
that you need, yes, I don't even think you need a PO2 of 100 or 120.
Right.
You could probably get away with a PO2 much, much lower than
Well, but
that
don't
and
you-
reduce that oxygen
Right.
free radical damage.
Well, likely so, but I think if you're using a circuit for this, you're going to have oxygen available. We know the body needs oxygen. I think that's the whole point of what they're doing with all these other things, is to try to help give the body the oxygen that it needs without having the negative effects. And that's why you're doing all these different parameter management, so that you can get the best of both worlds. You can get the oxygen that you need, as well as to help prevent cell death, but then as well as not getting the negative effects of the free radicals.
Right.
Yeah.
Yes, you're trying to find that balance
But-
point. But
right.
then we just listened to Matt and Joey talk to us. They don't even bring a blender. Of course, they're not worried about the brain, but for the heart, their PO2 is probably 700.
Right, but they're not worried about the brain.
Right.
Right.
If you're a live
but
patient-
you still have oxygen-free radicals that are going to be damaging to the myocardium, right?
Well, yeah. But we
And
don't
so-
know all the things that they're doing as far as, the different things they might be
They
doing.
are giving mannitol and the is it acetylcysteine?
Acetylcysteine.
And
But I was going to ask them about the leukocyte reducing filter. I wonder why they don't just incorporate one of those if it doesn't make much of a difference,
I don't know. It's a
Yeah,
good question.
The mannitol is going to be an oxygen-free radical scavenger, so maybe they get away with 150 to 200 PO2, and then the mannitol helps them. But I want to talk to you guys, if you can change the subject, not change the subject, but why are they doing this 7 pH, 7.25 pH lower than 7.25? Did they mean more acidotic? Because they're trying to avoid alkalosis.
Yes.
They keep
Yes,
saying.
right.
I
yes.
don't understand. I don't understand
Well,
that.
what they
Unless
said,
it's for go ahead.
their rationale, because I was curious about that too. Their rationale is that in order to lower cellular metabolism during the first 30 minutes of reperfusion until the substrates are replenished. So I don't know that you maintain a low pH the entire time. It's just in the beginning while you're getting substrates replenished. That's what it says.
But I didn't know that. I didn't know that acidosis reduced cellular activity.
I don't know.
I mean, I know that it increases, it shifts your oxyhemoglobin dissociation curve. I know that much.
Yeah.
But but I did not realize, at least I didn't know, that it reduced cellular metabolism.
Yeah.
Well, I can't tell you exactly, but I do know that cellular function and all enzyme function is blunted and mutated when you get acidotic. And so maybe there's a lot of science behind all the things that go on when your cells are somewhat acidotic, and it doesn't take much before cellular function is disrupted. And I assume that they're capitalizing on that and saying that it actually, therefore, then lowers the cellular metabolism because the cell cannot function normally. So maybe that's what they're targeting there.
Maybe so. But this
And the
is
same
very
thing
interesting.
With the high potassium, they're trying to make sure on the heart side of things that you don't have all this high activity
Right.
of the myocardial cells with a high potassium. I think probably do quite a bit higher than 6 to accomplish that.
Yeah, definitely.
So this
So
is
let me ask you guys this. How do they get their calcium levels below 0.5? Do you think they give the patient a significant amount of citrate?
well, that's what they said.
Yeah.
But they weren't able to get citrate in this case, so they probably became hypocalcemic just from the resuscitation, the dilution, and all that kind of stuff. So they just did not treat it.
Yeah. That's
but they would have normally, and they did recommend actually in the article
Yes.
that you were describing, that they were not able to get citrate at that time as fast as they needed it. So, but they didn't have to, because I guess it just naturally ended up that way through other mechanisms, but they did not correct it.
Which would have been their normal practice.
Their normal practice, right?
Yeah.
So in the big picture of this, it looks to me like they're trying to slow cellular metabolism, i.e. lower pH, higher potassium, lower calcium, so that the cell doesn't try to it lowers its metabolism to try to consume as much oxygen, I guess. Therefore, that may help with the oxygen-free radicals. Then they do the mannitol high. That's a lot of mannitol, and they try to decrease the oxygen-free radicals. And then they really do a lot to decrease cellular edema. If you look at the pulsatile flow, the high albumin, they even say that that the low calcium actually limits cell edema too, apparently, right?
And maintaining a basically normal, if slightly higher sodium level as well.
Mm-hmm.
Yeah.
Mm-hmm. Yeah, not very high.
Not very high, mildly.
But and then the potassium is for, and it's interesting because they keep their potassium elevated to reduce myocardial edema or myocardial oxygen consumption as well, which I thought was interesting.
Yep, and then body hypothermia, just 32 to 33 core temperature as fast as possible.
Mm-hmm.
So I'm thinking they hold the patient, they rewarm from 18 degrees. About an hour, hour and a half later, they land at 33 degrees, and they stay there for a while.
Yeah,
that's what I'm interpreting from this.
Yeah, it does seem like that's what happens. Because if you go back here, it says duration of pulsatile flow up to 60 minutes.
Yeah. But before you go any further, okay, the PCO2 of 35 to 45, and it says support pH stat strategy, and I always get these messed up. There's pH stat, there's alpha stat.
Mm-hmm.
Is it pH stat that is at 37, or is that the PCO2 temperature corrected?
Temperature corrected is, God, I always get this confused too. Hold on.
See, I do too. I'm gonna have to look it up because now I want to know because I always mess this up.
Temperature corrected is pH stat, and alpha stat is non-temperature corrected, right?
Yeah.
So
Yeah.
yeah.
So
because pH stat is typically used by pediatrics, right?
Yeah, and so they're really
because your actual CO2 content is much higher when you use pH stat with a PCO2 of 35 to 45.
Only if you're at 37 degrees.
No, they'd be the same.
Oh, no, yeah, they'd be the same at 37. Right, so the colder you are, the greater the variability in what you're...
The higher the CO2 content actually is.
Right, content versus what you are adapting it to be with the temperature, right?
Right.
Right.
Yeah.
So
as
pH
you cool
stat
the blood,
is pH stat acid-base management, and it says here that often CO2 is deliberately added to maintain the PCO2 of 40 during hypothermia, because your PCO2, your CO2 content is much higher for a lower PCO2 at hypothermia with pH stat than if you're doing alpha stat, which is actually measuring what the PCO2 is at 40.
Right, at 40.
So
At 37.
37. Yeah, because that's why pediatrics always have CO2 going into their circuit as well, right?
Yes.
Yeah.
95.5 or whatever they use.
Yeah, whatever it is.
And that strategy is believed to be cerebral protective, I guess, but they were going to have to, in order to keep a pH of below 7.25 with a pH stat, you're right, Joe, they're probably having to add CO2 then, because that would probably require that to keep a pH. And they say there on the CO2 supporting pH stat strategy, so they're keeping their CO2 in the normal range, basically around 40 being the midpoint there at that range.
And
But
so
they have to
that's
keep
why
it in
your
there to keep
pH,
that pH 7.25.
that's why your pH is 7.25, because it's a respiratory acidosis.
Mm-hmm.
Yeah.
Yeah, that makes sense now. Huh. Interesting. Had you ever heard of this method, the Carl method?
No. First time I ever heard of this.
Yeah. Hadn't
It's
heard of that.
fascinating.
It
I
is.
think you have to have a lot of preparation and plan, and you have to have this device. They call it the CIRD
Yeah,
device.
I wish I had included that. It wasn't included in their article, but I did Google it, and it's a whole little monitoring device, and yeah.
Yeah, I mean, I think it's very interesting, but it brings up therapeutic hypothermia.
Yes. It does.
Because actually we deal with this an awful lot, right? Although, you know, in our world, I mean, you get a patient who comes in through the ER, CPR, they resuscitated them, they bring them upstairs, and you see them, you know, they put the gel pads on them, they do all of this kind of stuff to try and control their temperature, and then they want to rewarm them by a half a degree per hour over however number of hours that they're going to do that to get to the temperature that they want, from 32 or 33 degrees, somewhere in that range, 34 degrees, whatever it is. Well, there's no way with an external device that you could be that precise.
Right.
My question has always been, would it not make more sense to use a cardioplegia heat exchanger, a Maherker catheter, you know, or a Quinton catheter, standard dialysis catheter with a little pump circuit hooked up to it, and control the temperature with a heater cooler much more precisely than you can with these external devices? I've always wondered why we didn't do that, other than the need for anticoagulation. But it would have to be, wouldn't have to be very much. It could be very mild anticoagulation. If you're cold, you don't clot very well anyway. So I don't even know how much of that you would actually need.
I don't know.
I've always thought, you have any experience with therapeutic hypothermia?
No, I've never lived in a cold state or worked in a cold state long
No,
enough.
I'm not talking about bumsicles.
Yeah.
I'm talking about therapeutic hypothermia. So
they have some sort of event, and so then you cool them, you know.
You're talking about the code cooling.
Yes,
Yes.
That's what I'm talking about.
Yeah, we'll do that on a circulatory arrest, and we go on, ECPR, Ecmo, and we'll do a code cooling from time to time. You know, it's controversial. There's two trains of thought about whether or not it is beneficial, but I think most kind of lean on the side that it is beneficial. And it's usually just 34 degrees or 34 and a half degrees for, you know, a number of hours, and then slowly rewarm back on the Ecmo device. It's about all I've experienced. And then some believe that it does have some, you know, minimization of the focal point of the ischemia areas will hopefully be minimized by doing that.
Well, it makes me really, you know, wonder whether or not we should be doing on any patient who goes ECPR for any reason, and you have any question about their neurologic status or concern about what their neurologic status will be, depending on how long they were without good resuscitation or unknown resuscitation. Two things. One, whether or not we should be running their PO2s down in the 50s, which we can do very easily with a blender. It's not hard to do, and an oxygenator, number one. And number two, whether or not we should be putting leukocyte depleting filters in these patients immediately. And, you know, you don't have to, you know, I mean, it seems odd to me they had to take 6 minutes to do that.
Well,
I
I
mean,
think they were doing
put
multiple
a bypass
things.
line in.
They were also washing out for any debris in the aorta. They were doing other things.
No, it said specifically it was 6 minutes to put a leukocyte depleting filter in. That's what it said.
Well, they
Yeah.
had to.
They also
There wasn't anything else going on.
They had
Yes,
to
there
cut
was.
the CPV
I read the
circuit.
article.
You read the article?
I read the article.
Can you pull the
They had
slides
to
up?
cut.
Yes,
They
share.
had to cut it
Yeah,
in line.
hold on. I
somewhere.
want to just read it real quick.
They had to cut it in line somewhere.
They
right?
had to cut in the lines, correct.
Yes. Hold on.
No, patient complication, ruptured, yeah, and second procedure, and rapid cooled.
Yep, it was after that.
Then I explained that. It's here. Yeah, but they were also inserting a femoral cannula. They were doing some other things. That was why they came off bypass, so they could switch to the femoral.
Okay.
But like there were a couple things going on.
Okay.
It wasn't 6 minutes just for the filter.
Okay.
I think multiple things were going on.
Okay. Yeah.
They did another debridement. They did some things. So
Okay.
anyway.
Because you can take and just run a leukocyte depleting filter just off of your recirc line.
Yeah.
You can do it through you can run it through a roller pump with a little 1/4-inch line if you wanted to, and a perfusion adapter.
Well, I think it depends on whatever they have.
It doesn't have to be in the main arterial line, right?
But yeah, they don't describe whatever they're using, so I don't know what their practice is. But it seems like they had to come off to go on the femoral cannula anyway.
Yeah. Okay. Well, fair enough. Okay, I agree with that.
Straight up recirculation lines, in most people's circuit is a dying breed. You don't see it very often anymore.
What's
Straight
that?
up just a recirculation line on your circuit for normal bypass.
Yeah.
That's a dying breed. You don't see that much anymore.
I'm not doing a case without one.
Oh, well, you're still doing the things from many years ago, and I'm saying it's a bad thing. It's a good thing, but 90% of the places I've always been or more, I don't see a recirculation line built into the.
What's the reason for removing it, I guess?
Oh, people have the confidence in the oxygenators now. They PO2s are 450, 500, not like the old days when it was, and it was more reliable. So people are much more comfortable now with the reliability and the capability.
Well, I think we don't even use it for that purpose.
No, we don't use it for that purpose. We use it in case we need to add something into the line.
Right,
You have
it's
a concentrator. You get air in it. You have
we run our our cerebral perfusion off of it.
Yeah.
I mean, it's more of an accessory for just a way to get in the circuit quickly.
Yeah.
Yeah, but yeah, you're right. I remember actually training, now that I'm thinking about it, that if you had a really large patient, you didn't think your oxygenator was going to perform, just kind of like we do on Ecmo, running your recirc line. But I haven't used it for that purpose. And
do you remember the Spiral Gold? The Spiral Gold, the oxygenator. Spiral Gold.
About the old.
The Baxter.
No.
It was Bentley. The Bentley Spiral Gold, dude. That oxygenator didn't work worth it. I needed that recirc line every case to have a PO2 to have a PO2 of like 90.
Yeah.
Yes, it was a terrible oxygenator, horrible oxygenator.
I'm glad we've come a long way. I remember being terrified that I was going to have to do serial oxygenators for really large patients because, they like drill that into you, what that's going to be like. And I was horrified by that thought.
Yes, the idea of
having to do that. Yeah.
Yeah, that was some fun. Those were fun times.
I've never had to do that, but they were still teaching
Those were fun times. Yeah, I remember. Look, I was using the Harvey that was the Shiley S100A. It was the Harvey H1500 or whatever it was that had the elliptical heat exchangers in it. That was supposed to improve warming times and all that kind of stuff. And I'll never forget a case I was doing that we had that thing going and I couldn't get the saturation, the PO2 never went above 70.
Oh my gosh.
The entirety of the case. I could not get it above 70, the PO2.
Did the surgeon work fast?
I mean, back then everybody worked fast. Back then you couldn't be a heart surgeon if you weren't fast.
Yeah.
But I was very stressed.
That's very stressful.
But Joe, you're talking about the old bubble oxygenator, Harvey.
Yeah, it was a bubble. Yeah, the Harvey H1500. Yeah.
Yeah.
There was the H700, then the H1000, and then the H1500, which was the more advanced heat exchanger.
Yeah.
They were elliptical in design to increase surface area. It didn't work. I mean, that was the only oxygenator, the only time in my career that I actually saw a water to blood leak.
Oh no.
We weren't on pub. I was checking it. I was testing it.
Yeah.
So it was before I primed it, and I actually was like,
where did that come from?
Is that water coming from? And I had a water to blood leak.
Oh my gosh.
In the oxygenator. Only one. That's all. That's the only one I've ever seen. And I've done a lot of cases.
Yeah.
I've seen a lot of cases, but that was the only one. And then there was another. I'm sorry, we're telling stupid stories. We're not even talking about your talk. But I can't help myself. And anyway, they called me into this room because we were using the Sarnes. I can't remember the name of the pump. I think it was the Sarnes 5000, if I remember right, the number of the pump.
The big Cadillac, huh?
And it had
That's what I trained on.
It had a big gooseneck with one of those shop lights on it and a big 100 watt bulb on it.
Yes.
Yeah. And the perfusionist had put it up against the reservoir and it melted a big hole in the reservoir of the oxygenator. And they called me in there and they were like, what do we need to do? And I said, well, I wouldn't let the reservoir fill up. I mean,
those do melt.
much-
I remember
how much longer do
doing
you have to
something
go?
similar to
Yeah.
that too. Not melting the reservoir, but a manifold line, one of those thin lines, was kind of in the line of fire of the light.
Yeah.
And at some point, I was like, oh, maybe I should angle this somewhere else. And my line was so pliable, just mushy almost. I was like, oh, I was melting that line.
Oh my God! I know. Yeah, that was so. So we finished the case. We finished the case with a big hole in the reservoir.
I don't know where I read this. Decades ago, I read this somewhere. Somewhere somebody wrote up some safety article and said that somewhere we have documented over 1,000 ways that perfusionists can kill the patient or have killed the patient.
Yeah.
You guys talking about ones that people never think of.
Never think of the light bulb melting something, but they were hot. They really were.
Well, I mean, I actually saw this happen. Yes, those light bulbs, but I actually saw this actually happen, where it was a place where I was working. I was relatively new, and there were multiple rooms. I won't say where it was or whatever. It doesn't make any difference. It's so long ago. But we were using bubble oxygenators at the time, and they had their vaporizer above the oxygenator. And, of course, the venous line, it was gravity drainage into a bubble oxygenator that came down and in like that. And then you had the top where the cardiotomy reservoir was separate, and it went into the oxygenator. So they didn't have an it was a separate cardiotomy reservoir, not an integrated one in the venous reservoir. It just had a sock, a defoaming agent sock. And they were filling their halothane and spilled it on the top of and it melted it.
Yeah.
It
I've heard of that.
dissolved it because it's a solvent. And I mean, and it all just like fell apart.
Yeah.
Like it was catastrophic. It was absolutely catastrophic. It just all just melted away. That was, and I've seen that with my own eyes.
I knew it could melt things if you dripped it on things.
Yeah,
but wow.
Dissolves it. Yeah.
Huh.
Yeah.
It's amazing. The anesthesia liquid gases and the what is it? The plastic
Polycarbonate. Polycarbonate. Yeah.
Is absolutely never supposed to come near each other because it is amazing.
Well, that's why.
That polycarbonate.
Yes, and that happened several times before it became standard to have the anesthetic gas vaporizer
on this side.
As far away
on the end of
and
that pump.
down below everything, right? So you don't have that mixing. Absolutely, very dangerous stuff.
Not only spills on your cardioplegia line. That's the only thing that happens now.
Yes.
That it's all the way over there.
Yeah. But it won't do anything to PVC. It's got to be it's polycarbonate. So it's polyvinyl chloride, like tubing. It won't do anything to it.
Okay.
But if you take a connector, even if you can find some fluorine or sevoflurane, either one, all of them work. Just take a regular polycarbonate connector and pour it on there and watch what happens. It'll still do it. It still does it.
Oh my gosh.
Yeah, very interesting stuff. So anyway, okay. So
do we have anything else on this? Are we ready to give it to John?
I think we are. I think we're ready to go into knowledge nuggets.
Yeah, we missed the knowledge nuggets last time. We're missing some nuggets.
This better be about albumin, John.
No, well, I don't. This topic is haptoglobin.
Okay, haptoglobin. Okay, because I was waiting for the albumin one because I have a lot of information on albumin. That's what I thought this one was about today.
I think this is last time. Yeah, was this supposed to be the one last time or no?
No, I don't think so. I don't know where you guys got that title. I never proposed that title.
Okay, all right. Well, anyway, I love albumin, but go ahead. It's haptoglobin.
That's a good one for.
Let's wait.
6 months.
We got to run your intro.
We got to run your intro.
All right, guys.
Roll it. Okay, we're back. Welcome back. John, floor is yours.
All right, guys. Glad to be back. So let's see. Hopefully you guys will enjoy today's knowledge nuggets. Let's see. All right, guys. So we are episode number 14. December 2nd, 2021, and I'm your host, John Ingram of John Ingram's Knowledge Nuggets, and as this episode has all previous and future, I hope to have no disclosures. So, Knowledge Nuggets, we have a motto at Knowledge Nuggets because it's a short, sweet nugget of knowledge that you're going to get, and we hope that you can just spend a little time and expand your mind. So, this week's topic is something called haptoglobin. And as you guys know, if you've never seen the show before, we try to take a noteworthy topic each session. We try to give you something that you can take home knowledge-wise with you. So if you see a little gold nugget in the upper right corner of the screen there, that'll be a snapshot slide that you can take a photo shot up and take home with you. And hopefully tomorrow you will be a better clinician with that little piece of knowledge with you. So hopefully it's just about 12 or so minutes. Then we do a surprise topic, something we call a gem of the week. You never know what that's going to be. Just a few minutes on that, and then panel discussion and questions. And if anybody out there ever has any questions or comments, and I'm certainly open to new comments about future shows, please email me at john.ingram@perfweb.us. All right, so guys, what is haptoglobin? Not something that I think most schools talk about in the education. I know it wasn't part of mine, but haptoglobin, we abbreviate this HP in this lecture, so look for that. Haptoglobin is a protein, and it's encoded by the haptoglobin gene that we have. Now, in blood plasma, free hemoglobin is released into the plasma, and it has a high affinity for the haptoglobin, or maybe we should say the haptoglobin has a very high affinity for the hemoglobin, because this haptoglobin, the purpose is for it to bind with the free hemoglobin. Now, after our red cells hemolyze from age, from natural aging, or from whatever reason, the haptoglobin is in the plasma, and it immediately combines with this free hemoglobin, and thereby it eliminates or pretty much inhibits or eliminates the deleterious oxidative activity that would happen had the haptoglobin not bind up this free hemoglobin. So the haptoglobin hemoglobin complex is then removed by the reticuloendothelial system. We're going to talk about all this a little bit more as we go. And also now, haptoglobin is produced mostly by the liver, but it also is found in other tissues like the skin, lung, and kidney produce a little bit of it, but mostly it's produced by the liver. And as I said, so the haptoglobin gene itself is actually expressed in our fat tissue, in the adipose tissue. Something interesting about that. So what is the role of haptoglobin? Well, haptoglobin is an acute phase protein, and its function is to bind with free hemoglobin. Now, this action prevents the loss of iron that would normally happen if haptoglobin did not bind with hemoglobin, and it also prevents the renal damage. All of us are familiar with when we have a lot of hemolysis going on, one of our big concerns is that free hemoglobin basically ends up going into the kidneys, and we often see red or wine-colored urine because of that. So haptoglobin itself also is an antioxidant. It has antibacterial activity, and it helps modulate many aspects of our acute inflammatory phase response. So it has some side benefits as well. So now, what is haptoglobin? What is the normal range? Well, if you were to measure it in the laboratory, and you can do that, and you should do that from time to time, it will range from 41 to 165 milligrams per deciliter, or some laboratories, and it varies from hospital to hospital, could measure it in milligrams per liter, which would be 410 to 1650. Now, normal value ranges may vary slightly among your laboratory. You might want to contact your laboratory to find out what they use for a normal haptoglobin range. And it is important to measure this from time to time. I'm going to discuss that. So, go ahead. So what happens now is, what does the haptoglobin indicate? So we can run a haptoglobin test, as I mentioned, and we can detect whether you have hemolytic anemia or another type of anemia. So let's say you have a low hemoglobin, a low H&H, and you suspect that you have some type of hemolysis going on. You just don't measure the level of your free hemoglobin in other parameters, and that will point you in the direction and actually indicate what your hemolysis is coming from, if indeed you even have hemolysis. Maybe you just have a poor production of red cells. So the haptoglobin is one test as part of a panel to determine what is going on with your low H&H. So haptoglobin may also determine the exact cause of why your red blood cells are being destroyed, i.e. the hemolysis. So the clinical significance of haptoglobin, now the reticuloendothelial system, as I said, will remove this haptoglobin hemoglobin complex from the body. So if you have a high amount of hemolysis, then the consumption of haptoglobin results in decreased haptoglobin levels in cases of high hemolysis. So when you have a high hemolytic situation, let's just say you have a clot in the centrifugal pump on your ECMO, for example. We see this all the time. And we keep adding blood and we don't know why. What's happening? Why do we have hemolysis going on? And we know we have hemolysis because we have a high free hemoglobin. Well, then we see, and we test our haptoglobin levels, and we see a very low haptoglobin level. That is very indicative also that you're having a hemolytic event, because it's depleting your haptoglobin levels. Go ahead. So now, also now on a clinical significance level, haptoglobin sequesters the iron within the hemoglobin, and this prevents the iron-utilizing bacteria from benefiting from the hemolysis. So if you have some type of bacteria in your system, maybe you've got a slight exposure, or maybe you're already infected, if this haptoglobin didn't sequester this hemoglobin, that free iron would greatly, it'd be like fertilizer to that bacteria. So haptoglobin has a very good benefit by capturing this free hemoglobin. And so therefore it's theorized that because of this, haptoglobin has evolved into an acute phase protein. So when we have an inflammatory response, a lot of times that is caused by an infection, the haptoglobin levels increase in hopes to capture any of the free hemoglobin that may be out there and help reduce and help mutate, or modulate the bacteria from capturing any additional iron and acting as fertilizer. So now the haptoglobin prevents free hemoglobin also from passing through the glomerulus, what I was saying earlier, where it causes damaging renal effects. So before we have any type of hemolysis, guys, as you know, our red blood cells have an approximate age of 90 days, and millions of them per second are being released into our system, and at the same exact amount, millions are reaching their old age and dying. So therefore, we have homeostasis with our hematocrit and hemoglobin staying the same. Well, where is all those millions per second of dying red blood cells and hemolyzing red blood cells? How are they being managed by the body? They're being managed by the haptoglobin, which is why we don't have damage to our kidneys going on normally because of this, and we don't have red urine. But when your haptoglobin gets depleted, which can happen very quickly, and you have hemolysis, now you have the free hemoglobin going through the glomerulus, going through the process that the kidneys try to process it, and that causes damage to your kidneys. So now, what are causes of low haptoglobin? I've already touched on a little bit. Decreased or absent haptoglobin levels are seen in the following conditions. As I mentioned, it could be intravascular hemolysis in conditions like spherocytosis or pyruvate kinase deficiency, autoimmune hemolytic anemia, transfusion reactions would be, and also we know on bypass and on ECMO, we could have mechanical reasons. But you also can have extravascular hemolysis, as in intraperitoneal hemorrhage. Now, you would think that in extravascular hemolysis, you would not see a decrease in haptoglobin, and that is largely true. In severe cases of extravascular hemolysis, it will eventually make its way into the system, and you will see a drop in haptoglobin. So this is one reason why the haptoglobin test is important. You could be having a lot of drop in your H&H, your hemoglobin and hematocrit, and say, hey, we have hemolysis going on, but then you see that your haptoglobin levels are normal and they haven't dropped. So that tells you, hey, something intravascular hemolytic-wise may be happening. So this is, you see the value of this haptoglobin test now. So the physiology of low haptoglobin, the haptoglobin is being consumed faster than the liver can produce it. So the result is a decrease in your haptoglobin levels. Low haptoglobin levels may be a sign of an anemic disorder. In other words, you may have a disorder where you're just not producing enough haptoglobin, as in liver disease and so on. So what about having a high haptoglobin, higher than normal range? Well, the increased production of haptoglobin is an acute response to inflammation. So you may just be having an acute inflammatory response, and you test your haptoglobin, you see it's actually higher than normal. Haptoglobin is an acute phase protein stimulated by any inflammatory process, infection, burns, major crush injury, allergy, etc. So also, increased haptoglobin levels may indicate an acute rheumatic disease. As you guys know, that's high inflammatory. And myocardial infarction, again, this is an acute response. Your haptoglobin levels may increase. Ulcerative colitis or persistent infection. So all of these things are inflammatory, and haptoglobin has evolved over the centuries and years of our evolution to become part of the inflammatory response defense. So what is the test protocol? Like when should we test for this? Measuring the level of haptoglobin is ordered whenever a patient exhibits signs of anemia. We're having problems keeping our hemoglobin and hematocrit up. Such conditions could be pallor, fatigue, shortness of breath, jaundice, dark-colored urine. Ecmo could be on there. The test is part of a hemolytic anemia battery of tests, which also would include, so you'd have your haptoglobin test, you'd do a reticulocyte count, a peripheral blood smear, direct antiglobin test, and bilirubin test. These are all going to help you indicate where your anemia may be coming from. So now, primarily, you're going to be talking about intravascular hemolysis, so we're going to talk about how to interpret this battery of tests that I just listed there. 4 different interpretations primarily. So how would you diagnose that this is an intravascular hemolytic problem that we're having? Well, first of all, you'd have anemia. That's going to be true with almost all these. So you have a drop in your red cell count or your H&H, and you have a decreased haptoglobin. So now you know you have an intravascular hemolytic situation because you're dropping your red cell count, and the haptoglobin is capturing all these hemolytic cells that are happening intravascular. So you have a drop in your haptoglobin level, but then you have an increase in your reticulocyte count, because what's happening is the reticuloendothelial system has to phagocytize this haptoglobin hemoglobin complex, and so it's been ramped up. So this interpretation is hemolysis within the vasculature, haptoglobin being consumed, and your reticuloendothelial system being activated. Now, what about extravascular hemolysis? Well, you'd have a drop in your red cell count, you have anemia, but now you have a normal haptoglobin. It's not being consumed because it's extravascular. And you also have an increased reticulocyte count because, again, your RES system has been ramped up. So this tells you that you have hemolysis outside the vasculature, and your haptoglobin is not being consumed. So that's extravascular hemolysis. So what about just that you don't have hemolysis at all? You just have a low red blood cell production. So you have anemia going on, but you have a normal haptoglobin. You have a normal reticulocyte count. So that hasn't been ramped up. So you have an anemia not due to hemolysis. It's due to a low red blood cell production, for example, aplastic anemia. And then your reticuloendothelial system, actually in this case, has not been activated because it's normal. So what about the fourth thing? So you have failure to produce haptoglobin. So you've done a haptoglobin test, it comes back low, but you have a normal red blood cell count in hemoglobin hematocrit, but you have a decreased haptoglobin. You have a normal reticulocyte count. This is the liver failing to produce adequate haptoglobin. So you see how valuable this test can be when you have anemia. So now, guys, the gem of the week, and the gem of the week is something that we never know what it's going to be. And this week's episode of the gem of the week is, and as I said, could be just about anything. We've gone through this routine before, but I've kind of summarized it here. It could be just about anything, but this week, the COVID-19 variant Omicron that's been in the news here like crazy for like the last 4 or 5 days. I wanted to bring this to light and shed some truth about this particular variant. We're having countries being shut down. We're having all kinds of instituted mandates and things happening because of the fear of this variant that's popped up in South Africa. So let's look at what's really happening. So this is called the Omicron variant. There's the variant itself, B.1.529, was first reported to the World Health Organization in South Africa just a week or so ago, the 24th of November. In recent weeks, infections have increased steeply in that country, coinciding with the detection of the Omicron variant. So in other words, they've had an increase in infections, and a lot of them have been this particular variant. So the first known Omicron infection was just several weeks ago on November 9th. It was the first one that the known one that we first detected. So this has only been a few weeks old. So this variant does have a unique constellation of more than 30 mutations, some of which of these mutations are rise for concern. That doesn't mean it's going to be good or bad, but some of these mutations, from what we know about COVID-19, are a little bit eyebrow raising, let's just say. Preliminary evidence suggests an increased risk of reinfection with this variant as compared to other variants of concern. Number of cases in Omicron is increasing in nearly all areas in South Africa. The World Health Organization has said it is not yet clear whether Omicron is more transmissible than other variants, or if it even causes more severe disease. But it has now been detected in about half a dozen or so countries, and we're hearing about more countries that are finding a couple cases here and there. It's still largely in South Africa, but we have a very small world nowadays. So Omicron, dubbed a variant of concern, a lot of times they abbreviate that as a VOC, but a variant of concern, last week by the World Health Organization, that it is potentially more contagious than previous variants. And this is just based on the anatomy of the mutations and all the different things that they're seeing on it, that it does have some concerns on the anatomical level under the microscope. So now let's look at the most important part of this. And I'm not trying to be an alarmist or an anti-alarmist. This is from Dr. Angelique Coetzee, the chairman of the South African Medical Association, stated, and this is just a few days ago, so far, patients have not reported a loss of smell or taste, and there has been no major drop in their oxygen levels and no prominent symptoms. This is a quote. And she says, symptoms of Omicron have so far been mild and have been largely treated at home. So this is why I wanted to bring this up today, because there's been this absolute hysteria that for some unknown reason has swept the world over this particular variant. But when you go to the actual medical director of the country of South Africa, this is what she has stated, and this is only about 42 to 72 hours ago, that this is what she is saying, is that this has been an extremely benign variant thus far. The alarm has come in when you look under it under a microscope and you see the mutations that it's gone through. There are several on there that have been of concern on some of the other variants. But this is where we're at with this particular Omicron.
Interesting.
All right, guys. So any comments and questions, future topics, or questions about a previous show or this one, again, please email me at john.ingram@perfweb.us. And I think the next slide we're going to be open to discussing haptoglobin and the COVID-19 variant Omicron. Thank you guys for listening.
Oh, thanks, John.
Very good.
Yeah.
Yeah, excellent on the haptoglobin. I don't think I have ever asked for a haptoglobin to be run. If I'm concerned about hemolysis, usually, because I'll have that happen. I've had that happen before where I've gone into the ICU and take over an ECMO shift, whatever, and the nurse says, yeah, the urine, they're bleeding from nowhere, but they're bleeding from their Foley. Well, how do you know that's blood? Well, it looks like blood, it's red. I said, well, how do you know it's not hemoglobin? You know, let's do an LDH. Mm-hmm. So I'll usually run an LDH, but I could run a haptoglobin, and if it's very, very low, right, then that would be, you know, so it could be a concurrent test to run an LDH and right, a haptoglobin or a plasma-free hemoglobin. For whatever reason, we don't do those very often anymore.
Yeah.
We can't get them at hospitals. So we ask for plasma-free hemoglobin. They're like, huh?
Really?
And yeah, I know it's strange, but you know, we just deal with what we deal with, right? We just have an alternative to everything that goes on. And you know, of course, I'm so burned out on COVID, but we keep talking about it. And of course, you know, I don't want to be political. I'm going to do my best not to be, but you know, we're depending on the comments by this physician from South Africa. But you know, it's not to say that they're right. You know, this is the problem that we're having. Is I've been wrong. We're having a meeting today, as a matter of fact. We've had several meetings, and one of the things that I've said is that I have been wrong about where COVID was going now 3 times. Mm-hmm. I don't, and I've been wrong in the wrong way. So I was wrong in believing it was going to come and it was going to go. Okay, it came back again, it's going to be gone. It came back again and it's gone. I'm not going to be wrong that way again. I'm going to assume it's going to come back with a vengeance. And I think that may be part of it, is that I have at least been wrong every single time, and we've been hit with it very hard, and it stretched our system to a near breaking point. We didn't break, but we got frayed, and I don't think we can afford that again. So I think a lot of what we're seeing is because of that. And then, you know, looking at the genetic makeup of this virus, you know, and the differences, you know, because they skipped a whole bunch of letters because there are so many differences in the spike protein. And I think that's what the issue is, from what I'm understanding, is that the spike protein is what the mRNA vaccines were predicated on. That's what the target is.
That's what they recognize.
And right, and that's exactly, and that those changes in that spike protein has now resulted in a very strong potential, not realized yet, but strong potential that the vaccines will essentially be rendered ineffective because it's not going to recognize that.
Well, I think what I had read was not that it would be ineffective or even a strong potential, but it could be a very slow responder to recognizing that spike because it is altered. Not that it wasn't going to recognize it at all. And
fair enough, yes, and I agree with you, yes.
And that's why they were, you know, all the vaccine manufacturers are looking at, do we need to increase the concentration of the boosters so that it will be quicker to react because it's not an exact match, if you will. But, you know, we're vaccinated against lots of different things, and these things are, many of them, still out there, and viruses change. They do. That's what they do. So I think people are panicking more that there's been this great improvement, and because of the vaccinations and because, you know, we sort of run the course on some of these people getting sick, and maybe the more immunocompromised are you know, dying, and the ones who are surviving, right? So they have some natural immunity. I think people are panicking because they don't want to take 2 steps back. It took so far to get here,
yes.
You know?
Yes.
So even though that quote that was brought up from, I think, someone who's likely very credible in South Africa is saying, although it's, you know, it's very prominent here, the people aren't getting that sick.
Mm-hmm. I think that is important, and I think it's. I mean, I do. It's the. I don't think that that's not important, and I am by no means intending to imply that that person's information isn't accurate for them. What I'm trying to say is that we have been told so many times now one thing and it was something else that I think there is a natural tendency to be even, we'll say, uber skeptical of anything that anybody says anymore.
Mm-hmm.
I think that's the issue.
Mm-hmm.
I'm not saying she's not credible or she's not accurate.
Mm-hmm.
It's just that we've heard these stories before.
Yeah.
Well, this is the director that oversees. It's the director of the Medical Association for the entire country of South Africa, and she personally has treated a large number of the patients that came through with this. Remember, it's only a few weeks old. You're only talking a few dozen patients. It's not like 10,000 people got infected with this in Africa. It's a few dozen, the last I heard, a week or so ago. And then these countries that I listed, they had like 2 or 3 patients,
yeah,
not
it's just
like
a couple.
hundreds. But the thing is, Joe, like you said, here's the problem. There's been 2 or 3 dozen variants, maybe way more than that. They've already gone through the alphabet.
Yeah, they didn't even talk about that.
They've gone through the alphabet, and then some of but the reason this is called Omicron is that they've already had all the other ones and they haven't used this particular letter yet. But there's been a bunch that they haven't even assigned a letter to, I think. But this particular one, by the way, it was primarily one patient that was dealing with the disease for an extended period of time and couldn't quite get over it and didn't quite die from it. So this particular virus stayed into his or her system for many weeks, and during that time went through many iterations, many variants and evolutions almost. And when they finally got contagious again and got released, and they got other people diagnosed, they found all over 34 mutations on this one virus, and it largely occurred on the one person that had it in their system for a long time. So they thought this was kind of interesting that it's a mutation, but it has a little bit of an element of an evolutionary effect, which, as you know, Joe, these things generally don't evolutionize; they just randomly change. But there's a couple things in this variant out of the 34 differences that they see on this one that are a little bit evolutionary. So that was kind of concern. And then, of course, the different spikes and things that we may or may not be being immune against right now because of the changes are the areas of concern. But the people that got the disease with this variant is one of the more mild, more innocent versions of the illness for COVID that we've seen. So I just think that's important. So you can be, that's actually what's happening though on the ground. The boots on the ground this is a very, very mild version of COVID-19.
Just for people, because I actually, when I must have read some of the same information you had, John, just sort of on my own. And I remember sort of wanting to understand what variant of concern meant. So I did a little reading, and I have it here on my phone. I'll just summarize briefly for anybody who's interested. That these are the classifications that the World Health Organization is using, which is, I guess, some variant classification that is normally used for viruses. So there's variants that are being monitored, VBMs, and those are just ones in existence, ones that they've identified. And it looks like there's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Most of them are named. There's 1 or 2 that just have numbers. I guess they were here and then gone and whatever. Then there's variants of interest, and that would be anyone that they're currently monitoring to see what's going to happen to it. Currently, there's none that are classified as a VOI. Then there's variants of concern. So only so far, Delta has been a variant of concern, and now the Omicron. And then there's the next classification would be a variant of high consequence, a VOHC, and there are none of those to date, at least that have been identified in the United States. And I was getting all this information off CDC's website. But each of these variants also have lineages, right? Because just because it's the Delta doesn't mean it stays the Delta. This Delta turns into all these different things, and they track those as well. And only if they become a lineage of consequence do they then highlight that it's that specific one. So like the Delta, the only ones that are variants of concern have a particular designation of like B.1.617.2 and the AY lineages, which I don't know exactly what that means, but I assume it's those certain mutations within Delta that are causing people to get sick. Mm-hmm. So there really hasn't been that. I think that's another reason people are panicking, is because this is only the second time there's been a VOC. And the Delta, you know, that was our last big wave, and it was just like you said, we kind of thought we had survived enough, and we were pulling back some of the social distancing and all of those things because vaccinations were up, and then people got sick again, a lot of people, you know.
Yeah, no, absolutely, and I think to say that Delta is not a variant of high consequence is naive, because it was very consequential.
Well, I think there's specific classifications for that.
No, I recognize that. I do understand that. I'm not arguing that. I'm just saying that I think Delta was a variant of high consequence. I think it was, in fact, highly consequential, and the number of people that got sick, the number of people that died, and what it did to our overall societies.
Yeah, and again,
so I don't know how bad it needs to get for it to be of high consequence.
Well,
but
I'll
it's gotta
tell
be
you
pretty
what
damn bad.
the attributes of what they are, because of course it's classification system, so you have to meet certain things. The what they say is impact on medical countermeasures, or MCMs. So it must demonstrate failure of diagnostic test targets. It must evidence to suggest a significant reduction in vaccine effectiveness, a disproportionately high number of infections in unvaccinated people, or very low vaccine-induced protection against severe disease, significantly reduced susceptibility to multiple emergency use authorizations or approved therapeutics, and more severe clinical disease, increased hospitalization. So it has to meet those things for it to be a variant of high consequence.
So they don't dare say that the vaccine wasn't effective, because then it would make it of high consequence. So let's just say that the vaccines worked, which I think they did.
I think you're trying to get a little controversial there. There's no evidence that they have not.
Me, controversial? Not me.
Anyway, so that's just for anybody who was sort of interested, because I was curious, since they were calling this a VOC, how important is that? What have we called the ones before? You know.
No, I think those are very good. I think those are very good points, and I appreciate you doing that. That was quite informative. So I think one of the things that bothers me a lot about understanding viruses, and one of the reasons why we're going to be doing an entire segment on viruses with an actual virologist who knows this stuff when we're in New Orleans. So that's one of the plans that we have for the New Orleans conference in the beginning of the thing, because this is a big topic. But this idea that and not to say we did here, but I think people think this, that viruses say to themselves, well, we want to continue to live, so we're going to continue to change in order to do that. Is not really how they work.
No, it's just sloppy, sloppy or quick reproduction, and so they just make mistakes.
But the reason why a virus proliferates accidentally, what makes it so widespread, becomes a pandemic or whatever it may, or becoming endemic, was the case may be, is that the more highly transmissible and the less immediately deadly the virus is, the more likely it's going to spread. So it's as if we are the ones that are the facilitators to the virus. We get it, we have it for 2 weeks before we have any symptoms. We've given it to a ton of people
Right.
before we ever realize that we're sick.
Mm-hmm.
And that's part of the mystery behind these viruses. The virus doesn't change in order to accomplish that.
Right, it's not smart.
If a virus hits you and like Ebola hits you and kills you immediately, it's just simply you don't have time to transmit it to people. Unless
it has a reservoir, right?
Right. If Ebola had a much longer incubation period, like HIV.
Yeah.
HIV was great. Now, it wasn't transmissible as easily as a respiratory virus is.
Culturally, at that time period, it was, right?
Well, it was not like a respiratory virus.
Right.
Right. So again, those things that are not controlled by the virus in any way are really more controlled by us in terms of all of this happening. And I find it just a fascinating subject. I'll tell you what, I always, I had basic understanding of viruses, but I've never really understood so much about them until this recent episode. I find it's a very fascinating subject.
And if someone sat down and thought about it, you don't even have to really understand viruses. If they just understood what you just said, you just explained exactly why social distancing works.
Yes.
Right?
Yes.
And why that was so effective before we had vaccines.
Yes. Yes.
Because we're the ones making it successful.
Yes.
Right.
Exactly. Exactly. No, that's very, very true.
Yeah.
And although I don't think masks are highly effective,
They
they
do
may
something.
3% maybe. I think but 3% is better than 0%, right?
And perhaps we'll have
what did Matt say earlier? Some blood flow is better than no blood flow,
yeah.
right? So 3% is better than 0%.
It's true.
It's not very effective, but it's if you add it all up, then it makes sense. Hand washing, all that. I mean, look what happened to the flu last year.
Right.
It almost didn't exist.
Right. Remember that article I read about because there were masks worn that the flu was so mild?
Yes. Yeah, almost non-existent. And it's amazing to me that it's not eradicated.
Yeah.
I mean, seriously.
Yeah.
How it's not eradicated is beyond me. But anyway, okay. John, great show, great program. We enjoyed it very much. I enjoyed your gem of the week. I thought it was very timely.
It was great.
And needed, necessary. So thank you very much for that. Tammy, excellent program on the Journal Club. That was a very interesting case. I really enjoyed it. Matt and Joey, I know you guys are busy at Vanderbilt, but for those watching, we appreciate so much their effort in this. I think that program is amazing at how many heart transplants they do and what they're doing to increase the number of
What do we have to do to get a ride-along?
That's what I want to do.
I want to do a ride-along.
Yeah, that's what I want to do. I don't want to do that damn case, but I want to watch
I want to watch it,
exactly. But to increase the number of donor hearts and helping some of these recipients. So are we ready to do the wheel?
Yeah.
Okay, so the prize winner today is going to be me, because I never win anything, and it's going to be me
Do we have any questions?
I have a question. I had plenty. So we're going to go to the wheel.
I'm looking for the wheel. Where's the wheel today?
Find the wheel.
There's the wheel.
Okay.
All right, I got to share the screen again. Okay.
Screen mirror.
There it is. Okay.
Yep. You got it? Did it come up? Yes.
There
Do
it
we
is.
have sound before she hits this?
Because it's no fun without the sound. Okay. All right. Well, let's give it a go.
Ready? Go.
Put your finger away. If you're going to win, you can't spin.
There's no sound.
There's no sound. Oh, okay.
Okay.
So just no sound for us. We don't get any fun.
Okay.
Nope. Let's go back to extra
No,
call.
I want a ball cap. Yes, on the first spin. I've got a ball cap. I'm going to pick one out and I'm going to wear it to the next show.
I'm spinning for you again. I don't think so.
You're spinning it for me again? Okay.
I want you to get something different. What is going on? Oh, okay.
And I win a $10 Amazon card.
No. I want you to get this.
So I get extra call. All right. Okay. No, see? my luck is changing. I always knew it would.
Yeah,
Up
I guess
to today.
finally.
I'm getting the ball cap. John, thank you very much. It was good seeing you. Tammy,
Yep.
great show. Appreciate everybody. We'll see you December 16th for a double perf web, one that I had to cancel and one that I'm going to do. And John, if you want to join us, please do. I'm glad you're doing well. And everybody, I hope everybody had a wonderful Thanksgiving. And we're going to get the last one for 2021 done. We're going to start back up again late January. We're going to get the schedule out. We're going to have this studio completely retooled. You're going to see a whole new look with all new technology. David and Magic over there have invested a tremendous amount of HET's money and MediWeb's money into buying all of this neat stuff. We're going to have
I thought you were going to say time, effort, dedication. They've invested tremendous amount of time, effort, and dedication.
And MediWeb and HET's money that we don't have. And but you know what? We have fun. It's enjoyable. I think that it brings value to our community. It's something that I see as worthwhile to do. And there's no question. I say this. I've said this before. I haven't said it for a long time.
So say it.
We're number one on YouTube. We're number one on Facebook. We're number one on the Twitter. And that's simply because we are number one. And 2022 is going to be a new year with a lot of neat stuff. And new cameras, simulations, new green screen, new studio look. You're just going to really, I think, enjoy yourself. So I'm looking forward to seeing you. But I'll see you on the 16th. It'll still be the same on that day. And we'll get through this. And thank you all again very much for supporting us and being a part of our system. And we'll see you on the 16th.
Have a great day.
Peace out.
Bye.